A compound fracture is nothing but a fracture which is exposed to the environment, right? Which is exposed to the environment, and this can result in what is called a dreadful complication in orthopedics, that is nothing but your infection. This ring X-fix is also called as Ilizarev ring external fixator. Right? Very important. It is asked in the exam. It results in relief of the pain, and this is also considered as a therapeutic treatment for the osteoid osteoma. It could be septic arthritis, but night sweats and weight loss and HIV patient. Again, we are putting the answer as tuberculosis. So that is how I have answered this as answer B, that is tuberculosis. So let's start the class without wasting any time now. So today I have come up with few questions directly. So we are going to learn everything in detail in orthopedics. We'll try to complete it by 3 to 4 hours. So let's start with the first question. So everything is inside hidden in the question itself. So first we'll read the question. We'll try to attempt the question, and then we'll understand what is important from that question in the exam point of view. Right. So now first let's try to answer this question first. Which among the following would be the correct order of the stability of fixation in type 3A compound fracture? So in this particular question, first what you have to understand is the compound fracture is a separate entity. Right? It is not like the normal fracture. The compound fractures are a different entity. Why they are very different? Because the compound fracture are prone for infections. What do you mean by a compound fracture? A compound fracture is nothing but a fracture which is exposed to the environment, right? Which is exposed to the environment, and this can result in what is called a dreadful complication in orthopedics, that is nothing but your infection. So you have to be very careful in treating this particular fractures. Right. So what is actually the important classification which you have to remember in case of compound fractures? Can somebody answer for this? What is the classification? Classification name. So this is Gustilo-Anderson's classification. So this is Gustilo-Anderson's classification. And how many types it has? There are 3 types in it. It could be type 1, type 2 and type 3. Right? In 3, again, what we have is A, B and C. Right? So in case of grade 1, so type 1 is nothing but again a grade 1, grade 2 and grade 3. So when do you say it is a grade 1 fracture? When you say it is a grade 1 fracture? Yashasvi, can you answer for me? When can you say it is a grade 1 fracture? What is the criteria which you have to take to say it as a grade 1 fracture? So whenever the wound, if you see once the patient comes to the casualty and you see the wound centimeter, if it is less than 1 centimeter, you tell this as a grade 1 fracture. If it is 1 centimeter to 10 centimeters, you classify this as a grade 2 fracture. Anything which is more than 10 centimeters is considered as a grade 3 fracture. Right? And in the grade 3, again, we have A, B, C as discussed. So A, B and C. Straight away, whenever there is a vascular injury, it is called as grade 3C. C is straight away whenever there is a vascular injury. Then what is the difference between A and B? So A is the soft tissue exposure and the periosteum is intact. So the soft tissue, whatever the damage is minimal, right? And here, so let us write this way. So here in grade 2, the soft tissue will be minimal. It could be moderate here. And grade B, there is a severe soft tissue injury. So what do you mean by a severe soft tissue injury? That means you need a help of a plastic surgeon to treat these cases. So whenever this case has been referred making up the skin, so that means it is a grade 3B. 3C is a vascular injury, right? So that is how you have to remember for compound fractures. So Gustilo-Anderson classification, 3 types, type 1, 2 and 3. Type 1 is less than 1 centimeters, which you can treat it like a normal fracture, right? So only there will be a very minimal, which is called as a very minor, it is called like just a point, like, or just less than 1 centimeters, very minimal, where you can give a thorough wash and you can fix it like a normal closed fracture. So why are we reading so much about this compound fractures? Because whenever you're dealing with the grade 2, And grade 3 fractures, what you have to do is the management differs from the normal fractures. The management is completely different from the normal fractures. So how does this differ? So in case of a normal closed fracture, if you're talking about a closed fracture, what happens is you can directly go for an internal fixation. But when it is an open fracture, you have to go for an external fixation, which is called as an X-fix. So in this X-fix, there are two types of X-fix which you have to remember. One type of X-fix is about your rods. The second type is rings. So there are rod types of X-fix and ring types of X-fix. This ring X-fix is also called as 𝐒𝐿𝑖ZAROV ring external fixate. Right? Very, very important. It is asked in the exam. And next, what are the rod type of X-fix? These are usually used more frequently, right? These are usually used more frequently, and these are there with pins. These are called Schwann's pins, and now they are fixed with rods and clamps. Right? So this is about the X-fix. So now what is this? What is this type of X-fix which I'm showing you on the screen? So is this a ring fixator or a rod or a pins fixator? What type of X-fix do you think this is? So this is a rod and a pin type of external fixator. If you see this particular pins, these are called pins. And how are these placed? This is called the fracture. And this is the fracture. Two pins are placed. So one pin placed near to the fracture. One pin is placed far to the fracture. This is how we will attain the stability. This is how we attain the stability, right? So this is how we have to put the pins. So two pins should be present near to the fracture to hold the fracture tightly, and to give stability to these pins, you have to put the other two pins farther away, right? And all the pins are connected by this is called the rod. And now these are called the clamps. The connection between the rod and the pin is through the clamps. So this is called the X-fix. External fixator, normal X-fix. Then what is this? What is this X-fix? This is a ring X-fix, external fixator, also called as 𝐒𝐿IZAROV external fixator. This is called as 𝐒𝐿IZAROV. This is called as 𝐒𝐿IZAROV external fixator. As this is a very cumbersome, it is completely giving stability in 360 degrees. It is highly stable external fixator, because now the fixation it is giving in 360 degrees, right? Full circle, it is giving you this stability. Right? So this is called the most stable type of fixation. But what is the disadvantage is? The disadvantage is it is usually cumbersome for the patient, because you see the whole limb with those rings and your clamps and the rods, it is little difficult for the patient to maintain. So that is why usually they don't opt for this, and we go for this is the uniplanar. So only one plane it is fixed, right? So this is only one plane. If there are two rods here, then this is called as biplanar. And now this is two rods are there. So whenever there are two rods, the stability increases. So in this there are two rods. So with the two rods, the stability is increasing, right? And now what is this? Yes, it can be also called as rail fixator. Yes, Shivani, you're right. It is 𝐒𝐿IZAROV. And then yeah, chances of ring sequestrum with 𝐒𝐿IZAROV is there, but usually any external fixator, the only thing which we are worried is about the infection, because we are putting the pins from the outside, right? So all the skin infection, or if the patient is not taking the care properly, that means they have to daily clean the external fixator. If they're not cleaning properly, then there is high chances of it getting infected. But ring sequestrum is not that common complication, but usually ring sequestrum is seen with this external fixator. That is it could be ring fixation or X-fix, or a normal, that is your rods or pins X-fix. Now what is this type? What is this external fixator called as? So this is asked in the exam. What is this fixation called as? If you see, there is one fixation above the knee. There is one fixation below the knee, and these two are combined by another rod. Yes, this is called as a spanning, and this is bridge spanning fixator. right? So when this is used particularly when there is a periarticular fracture. If there is a fracture here on the distal aspect or on the proximal aspect. So if you see, just imagine now if there is a fracture at this particular area. So there is no distal part of the femur, to give the support. If the fracture is exactly in the center like this, you will take the help of this particular bone at both the ends and you will stabilize it. But if the fracture is at the distal end of the bone, so there is no extra bone again to take the help. So now what you will do, you will take the help of the other bone, right? The bone which is present opposite to that joint. So now this becomes the joint, and now you take the help of the tibia for the distal femur fractures, or you take the help of the femur for proximal tibia fractures. So these distal femur fractures and the proximal tibia fractures together collectively are called as a periarticular fractures. That means they are present around the joint, and fixation of this joint is a challenging, and that is why you do this bridge spanning external fixate, right? So this is this was asked recently in the exam. Okay. Yes, for knee stabilization. Limb reconstruction also, yes, it can be used. That is usually whenever there is a dislocation or whenever there is a vascular injury also. If it is an open injury, we use this type of external fixator. These are called bridge spanning external fixator, right? Okay, now let us go back to the question here. Now, having understood so much about the stability of the fixation, now answer this question without looking at the answer here. So what would be the correct order? What would be the correct order of fixation? So first, I have already told you that Ilizarov fixation gives you the highest stability, right? So this is the 360 degrees. So this is the highest stability. Then always after 360 degrees, it is biplanar, right? So I've told you when rods are present on the opposite side, that is 180 degrees to it. So that is next highest, second highest stability is this. And then if a uniplanar fixation is 2 rods, it is more stable than 1 rod. So 1 rod gives you the least stability. So now what would be the correct order? So 4, 1, 2 and 3. So 4 is for least stability, 1 is the second one, biplanar, and then Ilizarov. So the answer for this is B, option B, right? Everyone agreed? So this is how you have to answer this question. It was asked in the INICT exam. Okay. So this is the correct order. So first Ilizarov is the highest, and then comes your biplanar, and then comes your 2 rods, then comes your 1 rod. Okay. So that is the answer for this. Moving to the second question. Organize the different steps involved in the Thomas test in the correct order. So you have to now organize the steps of the Thomas test. So first of all, let me know Thomas test is used for which part of examination. Like what does Thomas test tell you? Thomas test is used for what? So this is your Thomas test. So now this is your Thomas test. So what does this tell you? What inference we get from the Thomas test? This is mainly used for quantitative fixed flexion deformity. That means, what do you mean by fixed flexion deformity of hip especially? What do you mean by that? So in fixed flexion deformity, what actually happens is, so whenever you have some problem, whenever you have a issue in the hip joint, right? So now what happens is the muscles get contracted, especially the flexors of the hip are the first one to get contracted, and now the hip goes into flexion. But imagine if the hip goes into flexion, can you walk? Can you walk if the hip goes into flexion? You can't walk, right? So what does now the spine will come to rescue. Now the spine will tell, instead of you flexing, I will flex more. So that will result in more lumbar lordosis, which is called as exaggerated lumbar lordosis, right? So now to quantify this, so to identify this fixed flexion deformity, you have to make the spine straight. You have to tell the spine to relax, so that you have to quantify the fixed flexion deformity. How will you relax the spine? You will relax the spine by flexing the normal hip. Now you will tell the spine, instead of you taking the burden, the normal hip will flex. right? So that is the story of this fixed flexion deformity. So now what you do, you ask the patient to lie down on a couch. So on lying, what happens is the lumbar spine will relax and now the lumbar lordosis will come down. So the exaggerated lumbar lordosis will try to straighten up. This straightening, how will you do? You will flex the normal hip. So now see, so now this is your normal hip and this is your abnormal hip. Let us assume the normal hip and abnormal hip. So the first thing what you do, you put the patient in supine position and then you flex the normal hip. When you flex the normal hip, the lumbar spine will relax. When this relax, what happens is now this abnormal hip goes into flexion, right? Still now what is the part which is taking care of this? The spine was taking care. It was going into more flexion. Now what happens, once you flex the normal hip, the abnormal hip will goes into flexion. Now what you see whether it is like you have to identify the correct flexion deformity, right? You have to not do the exaggeration of that flexion deformity. For that, what you see that ischial tuberosity is touching the couch. That is your method to check whether it is a normal fixed flexion or an exaggerated one, right? So once you have identified that the ischial tuberosity is touching the couch, what you do is you put a goniometer. The goniometer is something like this with the two scales and there is one gauge for the degrees. So to identify the degrees, you have 0, 10, 20 like that. You have the degrees with the scale in it. So one scale, the one limb of the scale you put along the long axis of the femur and the other scale you put along the couch. And now this is the angle which it shows. So this angle is your flexion deformity. So this angle is your flexion deformity. So this is a quantitative test where you can identify the flexion deformity of the hip. What are the conditions where you see this flexion deformity? So usually we start with tuberculosis, avascular necrosis. So again, where various hip conditions where the patient will come with decreased movements of the hip joint. Usually we see this in avascular necrosis, TB, or primary osteoarthritis, or any secondary osteoarthritis, or it can also be seen in rheumatoid arthritis, right? All the hip conditions, right? So these are the conditions. Now let's go back to the question, and this was again asked in INICT exam. So in the NEET, probably they'll ask you, the Thomas test is used for fixed flexion deformity, but sometimes they may put up the sequence also, because this is usually asked in the Viva, right? So now let us see what is the order of this. So can you help me to identify the order? Yes, iliopsoas contracture. Yeah, this is contracture is something. Contracture is something where the flexion deformity. See, contracture is something where the entire muscle goes into fibrosis, right? So here the muscle doesn't go into fibrosis actually, but because of that weakness, or because of the sphericity of the head is lost, or because of that loss of movements, the flexion deformity occurs. Contracture is something where it entirely goes into fibrosis, and it will stay in that flexion. The spine doesn't try to compensate so much in the contracture. But if it is an initial stage, probably you can identify, right? And next, what are these steps? Can you help me with the steps? So the first one, as I've told you, the patient has to sleep, that is supine, and then you're going to flex the normal side of the hip, and then see, first one, what you have to do is, so patient will finally sleep, that is in the supine position. So you will check for the exaggerated lumbar lordosis, right? And then you will flex the normal hip. So this is the first one, what you're going to do. And this is the second one. So once you flex the normal hip, then what happens is you have to always check for the pelvis. So pelvis try to rotate. So this rotation of the pelvis is corrected by what is called as squaring of pelvis. This is rotated by what is called as squaring of pelvis. And once you do this, you have to, I told you, you have to ensure that the ischial tuberosity is touching the couch. And then finally, you will measure the fixed flexion deformity. So the answer is, so the first one you have to go for 1, 5, 2, 4 and 3. So the answer is, first one you have to go for the exaggerated lumbar lordosis, then you go for flexion of the normal side of the hip, right? And then you're going to do squaring of the pelvis, right? And then you ensure that the tuberosity touches the couch, and finally you will measure the actual flexion deformity, right? Hope you all understood this question here. So this is about the flexion deformity of the hip. Now similarly, what is this? What you see this in the picture, this is called as the Thomas splint. This is not to confuse with the Thomas test. This is your Thomas splint. So where do you use this Thomas splint? The Thomas splint was originally designed during World War II for treating the patients with tuberculosis. And later, this Thomas splint is now used for shifting the patient or for immobilization of the patient who are suffering from femoral fractures. So whenever there is a fracture femur, you need some support which is given to the patient, right? So now this is used as a traction tool, or you can use it as an immobilization splint, right? Immobilization brace or splint, which is called as Thomas splint. What you have to remember is this is a ring like structure which is present, and now there are two rods. So this is called the outer rod and this is called the inner rod. So how do I identify the outer rod and the inner rod? So outer rod, it has a small elevation like thing to accommodate the greater trochanter, right? And now this inner rod will make an angle of 120 degrees, right? So this makes an angle of 120 degrees with the ring. So this is the angle. So this is what the thing is, this Thomas splint has to be assembled. So you will get a ring size, you will get the rod, and then you have to attach it. So you have to take the circumference, you have to measure the circumference of the thigh, and then you have to identify the ring, and you have to get the two rods, and then you have to prepare this Thomas splint. So for that, you have to understand that there is a ring where you have to measure the highest circumference of the thigh. That is the diameter of that particular ring. And then you have to identify the rod, outer rod, with a small projection like this. So this projection or elevation is to accommodate your greater trochanter on the lateral aspect. And the inner angle is making an 120 degrees, which is a straight rod, and these two are connected with a W-shaped structure. And now what you do, you put the gauze piece or a roller bandage like this, and you create a layer over there, and now you put the limb, and again you will put the crepe bandage or the roller bandage so that it is fixed tightly to the Thomas splint, right? So that is it. So there are two things of Thomas. One is the Thomas test, which is used for the fixed flexion deformity of hip, and the second one is the Thomas splint, which is used for the femoral fractures. And this Thomas splint can sometimes also be used for the fixed traction. So now what you do, you put the limb there and you can use a fixed traction. So you can tie traction to that particular limb also, because here the whatever the two rods are there, no, they will act as giving it a firm stability to it. So this is called a fixed type of traction, right? So this is about the Thomas test and the Thomas splint, right? Understood? Let's move on to the third question. Yes, very good, Shivani. Thomas splint. Yes, very good. Thomas femur fracture and femur shaft fracture. Very good. So that is it for the Thomas. Then can you tell me what is Thompson's test? Can somebody tell me what is Thompson's test? Thompson's test is used for? So the Thompson test is used for your tendo-Achilles. So whenever there is a tendo-Achilles tear, so this tendo-Achilles tear is identified by the Thompson test. So how do you do this Thompson test? So Thompson test, how do you do it? You have to, very good Komal, it is for tendo-Achilles. So you put the patient in prone position. So how is the tendo-Achilles tendon formed? The tendo-Achilles is formed by two important muscles, the soleus and the gastrocnemius, right? So you will put the patient in prone position like this, and what you do is you squeeze this muscles. So you squeeze the muscles like this, and once you squeeze the muscle, so this is the prone position of the patient, and this is the thigh, and this is his leg like this, right? So what you do, now this is the area of the leg where the gastrocnemius and soleus are present. You will squeeze, and now there should be a plantar flexion. If there is no plantar flexion, that means there is a tear in the tendo-Achilles. So that is your Thompson's test. So that is your Thomas test, Thomas splint, and your Thompson's test, right? Now, next question, match the following conditions with the correct management. So here we have certain conditions. The simple bones is the osteoid osteoma, the GCT, the osteosarcoma. So let us understand So let us see what are the options for it. So first, coming to the simple bone cyst. So this is your simple bone cyst, or it is also called as the unicameral bone cyst. So what is happening here is there is a cyst. What is a cyst? It is a fluid filled cavity. So this fluid filled cavity is present in the bone, fluid filled in the bone. And usually this cyst is not so aggressive, and it usually obeys the rules of a benign tumor, and it is not like, it doesn't cross the borders, it doesn't irritate the other structures behind it. It is just a fluid filled thing which is present inside the bone, and it is a lucent structure. You can see there is a lucent structure. And what you have to remember more about the simple bone cyst is, whenever there is a fracture, the fallen leaf sign. So what is the sign which is related to the simple bone cyst? The fallen leaf sign or the trap door sign. The fallen leaf sign or the trap door sign, right? And then how do you treat it? Usually we give intralesional steroids. So usually we give the intralesional. So you have to go to that particular cyst and you give the intralesional steroids for it, or it usually because of the steroid, the cyst generally gets dissolved, right? So what is more important is this thing. So if you see the diameter, this and this, right, it usually obeys the width of the bone, right? It usually obeys the width of the bone. If you can see, it doesn't cross the width of the bone. But when you come to the GCT, or you come to the aneurysmal bone cyst, if you see, this is the width of the bone, it extends. So this is an aggressive, eccentric lesion, right? So this is an example of GCT. So that is how you have to see for the simple bone cyst and the aneurysmal bone cyst also. This doesn't, usually both the other cysts are very aggressive, very expansile. They get more, they go into more width than the width of the bone, right? So this is about this simple bone cyst. So what do you think is the treatment for it? The simple bone cyst, usually we treat with the intralesional steroids. So usually we treat with the intralesional steroids. Then what is the next one? The next one is this. So what is this? What is this? You can see something which is called as nidus. And what investigation is this? Is this a CT scan or an MRI? Yashasvi, Shivani, Komal, is this the CT scan or the MRI? So this is a CT scan, right? So this is a CT scan, and you can see there is a nidus here. So this is the nidus. So this is a small nidus, and usually on the X-ray this is seen as less than 1 centimeter lesion, and on the X-ray usually this nidus cannot be appreciated, and what you see is just a periosteal reaction. What you see is just a periosteal reaction, right? And now when you go for a CT scan, so always remember, whenever you want to identify something in marrow, you go for an MRI, and something you want to identify in the cortex, you go for a CT scan. So this is a golden rule which you have to remember. So whenever you want to identify marrow, you have to go for MRI, and whenever you want to identify something in the cortex, something related to calcification, something related to bone in detail, then you have to go for a CT scan. Navodit, MRI. This is MRI. Do you think, Shivani and Navodit, is this an MRI? This is a CT scan. This is a CT scan where you can see this is the bone which is seen clearly, right? So this is the CT scan. So here what you see is this is the nidus. And which condition you go for the CT scan? Yes, that is your osteoid osteoma is one tumor where you first order for a CT scan. So because it is related, this is a bone forming tumor, osteoid osteoma, right? So this is the nidus can be seen in the cortex. And what is very peculiar feature of the osteoid osteoma? What is very peculiar feature of the osteoid osteoma? It was asked again in recent exam. So the peculiar feature is, yes, very good, Komal. It is the aspirin response. So what happens is usually the patients with osteoid osteoma, they suffer with night pains. And why night pains? Because this tumor as a condition where the prostaglandins are released. The prostaglandins are released, and when you treat them with aspirin or NSAIDs, aspirin or the NSAIDs, it results in relief of the pain. And this is also considered as a therapeutic treatment for the osteoid osteoma. But when the pain is not relieved with osteoid osteoma, what you have to do? When the pain is not relieved with osteoid osteoma, what you have to do? You have to explore the other options. It could be a osteoblastoma, which is a very, very relative condition, right? It is very much related to osteoid osteoma. Here also you will see nidus, but here what happens is the nidus will be more than 2 centimeters. So when you think nidus, if you see whenever there is a nidus inside the bone, when it is more than 2 centimeters, you have to always think about other conditions such as osteoblastoma. But one more important thing, what is the most common area where this osteoblastoma is seen? It is mainly seen in the vertebrae, especially in the posterior elements, especially in the posterior elements of the vertebrae, right? So posterior elements of the vertebrae. Yes, very good. Komal, Navodit and Shivani, very good. So remember, osteoid osteoma less than 1 centimeter. If this particular nidus is more than 1 centimeter, explore other options. If it is not relieved with aspirin, explore other options, right? So one such option is your osteoblastoma. And what is the most common site for this osteoblastoma? It is usually in the vertebra and especially in the posterior elements. If you remember, the vertebra is divided into 3 columns, right? The Dennis column concept. The anterior, middle and the posterior, right? So if you think this is the vertebra, this is the pedicle, and now this is the structure, right? So now what happens is the Dennis has divided it into middle, that is anterior, middle and the posterior. So this osteoblastoma is most commonly in this posterior elements, right? So that is it. Now, how do you treat this osteoid osteoma? The treatment of osteoid osteoma is, let's go back here. So the treatment of osteoid osteoma, this can be treated with your radio frequency ablation. So the answer here is 3. So it can be treated with radio frequency ablation. Then coming to our favorite topic, which is very, very important, and the exam doesn't end if they don't put question on this. So what is this? Yeah, GCT, see, osteoid osteoma is less than 1 centimeter, right? So usually excision is not an option. So what we go for is radio frequency ablation. So usually we go for radio frequency ablation. So what is this? Next is your giant cell tumor, your GCT. Very, very important in exam point of view. So I know you all have read in detail about this. This is not ABC. This is GCT. This is ABC. Yeah. Why did I tell this is ABC, not GCT? Yes, Shivani is right. This is aneurysmal bone cyst. Now I will tell you how to differentiate, because see, listen, whenever you want to tell this is as GCT, the epiphysis is the key. So epiphysis, you see there is nothing there. So you see that tumor is mainly in the metaphyseal region. And let's go back to GCT here. So this is GCT where you see the epiphysis is involved. If you can see, the epiphyseal region is also involved. So whenever the tumor is from epiphysis, please remember, if the tumor is from epiphysis, it is your giant cell tumor. This is your giant cell tumor, which is from the epiphysis. But when you see this, see, Shivani, yeah, yes, this is the metaphyseal region. So this region is this is the epi, this is the meta, and this is the dia. So always remember, the ABC is from the metaphysis. The ABC is from the metaphysis, right? So very, very important. And one more thing, whenever you have a doubt, see, usually it is not like once we see the X-ray, we come to the conclusion. It is always, whenever you're dealing with the tumor, you have to always go up to the biopsy. Sometimes this ABC can also be some other thing also. So whenever you go for an MRI, so now what is this? Is this an MRI or a CT scan? So this is an MRI where you see very peculiar feature for your ABC, that is your aneurysmal bone cyst. So what is that feature? That is fluid levels. Multiple fluid levels are seen. So if you go for an MRI for this particular thing, so for this particular thing, when you go for an MRI, you see there is a fluid filled, there is a fluid level. So multiple fluid levels are seen, and that is how you differentiate between your ABC and your GCT, right? So MRI, you see multiple fluid levels. So these are the multiple fluid levels you can see. So what is this ABC? ABC is nothing but aneurysmal bone cyst where blood is filled in this cyst. It is a blood filled cyst, and this is also aggressive. It is aggressive and it is expansile. Right, it is expansile and it is eccentric also. What do you mean by eccentric? So it is present to one corner, and if you see, I have told you that the width of this is equal to the width of the cyst. But here if you see, this is the width of the bone, but this has extended, right? So this meaning it is expansile. The meaning of this is expansile. So this is ABC, right? So aneurysmal bone cyst, where you see it is similar to the GCT, but its main thing, it is location is its metaphyseal, seen in the metaphyseal region, right? And then we are going to the GCT. So this is your giant cell tumor, and most important thing of your giant cell tumor is this location is the epiphysis. So for identifying the tumor, always look for the location. So few tumors arise from epi, few tumor arise from meta, and few from diaphysis. For example, epiphyseal tumors are your giant cell tumor, very important giant cell tumor. Right, metaphysis, most of them are from the metaphysis. So let's not remember that. And diaphysis is very important again, because minimum, that is Ewing's tumor, Ewing's sarcoma is from metaphysis, where you see Ewing's tumor is from the diaphysis, right? So most of them, like your osteosarcoma, your osteochondroma, infections are also most common in the metaphyseal region. But when it comes to diaphysis, it is Ewing tumor, it is fibrous dysplasia can also be seen in diaphysis. Right, osteoid osteoma is also seen in your diaphysis. So this is how you have to remember. So whenever you see a tumor, you have to first identify whether it is coming from the epi, meta, or the diaphysis. If it is epiphysis, giant cell tumor. And one more important thing is your chondroblastoma. So one more important epiphyseal origin is your chondroblastoma. So GCT and chondroblastoma. Yes, Komal, you're right. GCT and chondroblastoma, these two occur from the epiphysis. The second, most of them are from the metaphyseal, and Ewing's and fibrous dysplasia, osteoid osteoma is from your diaphysis. So here if you see, this is a GCT, and in the GCT what you see is this is also eccentric and this is also expansile. That means it is very aggressive. It encroaches on the joint but never crosses the joint line. And most important thing is it is always seen after skeletal maturity. It is after seen after skeletal maturity, right? So the epiphysis closes, and then it is the GCT is seen there, right? And then what is the treatment of this? The important thing is the treatment of the GCT. So how do you treat the GCT? This is called as the extended curettage. This is called as the extended curettage. What do you mean by the thing extended curettage? So what is actually curettage? So once you see this X-ray on the in your OPD or somewhere, so what do you tell the patient? You tell the patient that this is a very aggressive tumor. What is the meaning of aggressive? That means there is always a chance of recurrence. There is always a chance of recurrence. That means once you treat the tumor again comes back. So what you have to do for it not coming back? So what you do is you open the bone, you curettage, that means you completely curate the bone. You will scrape the entire bone, and now what you do is you put certain things which is called as the liquid nitrogen, or you put a bone cement, or you put any other muscle grafting. So all these things are put inside it, and then it is closed. So why do we do this? We do this because the tumor cells which we can't reach to certain ends, so these also will die. So liquid nitrogen, bone cement, these are the adjuvants which we used for the extended curettage. So whenever we do these things, Whenever you put these things, so that means it is called as an extended curettage. So normal simple curettage, you can go for the simple bone cyst. Simple bone cyst also you can go for curettage, right? And the treatment is extended curettage for this, that is the GCT. And then what is this? Very, very important. Yeah, liquid phenol also can be used. Very good. Yeah, liquid phenol also can be used. So all these are called as the adjuvants, the liquid nitrogen, the bone cement, and the liquid phenol. So all this, they kill those leftover tumor cells which cannot be scraped. And one more thing, what you see on the biopsy in case of GCT, the biopsy is very, very important. This can be asked as an integrated question. So now you do the scraping and you send this content for biopsy. So for biopsy, what you see? You see multiple giant cells. So you see multiple giant cells. Hence, it is also called as the osteoclastoma. Multiple giant cells among the mononuclear cells. And probably they can ask you this also. Nowadays, what they are doing is they are giving denosumab. So this denosumab is used before surgery to decrease the size. So to decrease the size, this denosumab is used to decrease the size of the tumor. Right, so this can be asked as a recent advancement, right? Just remember the drug which can be used in the treatment of your GCT, please mark it as denosumab. So denosumab has been proven, I mean research has been done and it has been proven that 6 weeks of denosumab is given, usually in the dosage of 120 milligrams. So this is given as a dosage, and so that it will so that the size of the GCT comes down, and sometimes there will be a sclerotic margin which is formed around the tumor, so that this scraping becomes even more easy without creating any pathological fractures, right? So that is about the GCT. Yes, very good. This is sunburst appearance. So this is called a sunburst appearance, and it is usually seen in osteosarcoma. So what is this osteosarcoma? So osteosarcoma is supposed to be the most common malignant tumor. So most common malignant, that is a malignant bone tumor. But whenever somebody asks you most common malignant tumor in skeletal system is multiple myeloma. It is still multiple myeloma which is the most common, but when they specifically mention bone, so multiple myeloma is something which is related to blood, right? So whenever it is bone, it is the most common malignancy which is seen, and it is usually seen in 10 to 20 years of age group. It is usually seen in 10 to 20 years of age group, right? And this shows two important radiological features. What you have to remember is Codman's triangle. Codman's triangle is nothing but it is an elevation of the periosteum. It is elevation of the periosteum. And the second one is this, the sun ray appearance. The sun ray appearance or the sunburst appearance. So what is the sunburst appearance? This is nothing but, as you all know, the osteosarcoma is a bone forming tumor. So this is a bone forming tumor. That means this tumor will form bones, right? So this bone or the calcification which is forming, it is formed along the vessels or the Sharpie's fiber. So it is formed along the vessels or the Sharpie's fiber. What are the Sharpie's fiber? These are the fibers which are attached. The periosteum is attached to the bone through this Sharpie's fiber. So whenever there is a calcification along this vessels, so these vessels are something like this, and this, whenever there is a calcification along these vessels like this, so this calcification, now it appears as a sunburst appearance or the sun ray appearance. So this is about the osteosarcoma, and usually the osteosarcoma nowadays, it is treated with neoadjuvant chemotherapy. It is treated with neoadjuvant chemotherapy followed by surgery, right? And residual chemo. Right? So this is how they treat. There is no role of radiotherapy in case of your osteosarcoma. So neoadjuvant chemotherapy is playing a very important role in case of surgical treatment of osteosarcoma, because most of the amputations rate has been decreased. The amputation rates has been decreased. Right? So this is about the treatment of osteosarcoma. Right? So neoadjuvant chemotherapy like adriamycin, vincristine, these are the drugs which are used, and now after the chemotherapy, the patient will be subjected to surgery, and this is a little complex surgery which depends upon the extent of the tumor. So you have to first order for an MRI, and basing upon the MRI, you have to trace the tumor, and you have to then go for a knee replacement surgery with various customized prostheses for that particular patient. And then afterwards, you can put them on chemotherapy for maintenance, right? So this is about the osteosarcoma. Now let us go back to the question. So GCT, what did they tell? The GCT is, so the treatment of GCT is, so this is an extended curettage, and osteosarcoma is wide excision. So wide excision, or it could be a complete removal of the part of the limb also. It could be an amputation, but usually as per this table, it is taken as the wide excision. Yes, it is radio resistant. So that is the answer for this 3, 2, 3, 4, 1. C. The answer would be C. So please remember that the simple bone cyst is treated by the intralesional steroids, osteoidostoma by radiofrequency ablation, and even ABC, the aneurysmal bone cyst, also is treated by radiofrequency ablation, right? And osteosarcoma is a very wide excision, like you have to completely remove the entire tumor and its compartment, right? Okay, any doubts? Any doubts? Please let me know. So no doubts when we are moving forward. So what are these named fractures? So these are very, very important. These named fractures are usually asked. There is nothing much to learn about it. Just you have to remember them. So here there are certain named fractures. So what is a Jones fracture? A Jones fracture is? Yes, it is a base of the fifth metatarsal. Base of the fifth metatarsal is Jones fracture. What is March fracture? March is second metatarsal fracture. What is a Bennett's fracture? Bennett's is base of the first metacarpal. Boxes is neck of the fifth metacarpal. Hope you all have done it right. Yes, right. So let me ask you, what is a March fracture? What type of a fracture is a March fracture? What is the other name given to it? It is a type of March fracture is a type of a stress fracture, right? What is the meaning of stress fracture? Whenever there are continuous abnormal forces. So there are continuous abnormal forces acting on the normal bone. This will result in the fracture. Example, the March fracture or the fracture hip. Right? So continuous abnormal forces which are acting on it. Then what is a pathological fracture? Pathological fracture is again these abnormal forces, but please remember, whatever these abnormal forces are very, very minimal forces, trivial forces, not aggressive forces like the trauma. So these forces usually don't cause fracture in the bones, but because there is a continuous forces, continuous stress which is given to the normal bone, there is a stress fracture, and this minimal force when acting on an abnormal bone results in what is called as the pathological fracture. Right? So you have to remember there are two important things, the stress fracture and the pathological fracture. So example of pathological fracture is again the various fractures which you see in tumors, which you see in the loser zone, right? The pseudo fractures. So these are the examples of the pathological fractures. So two things, stress fracture and the pathological fracture. So these are certain eponyms, the Jones fracture, March fracture, Bennett's fracture, and the Boxer's fracture. What is the fracture Rolando? Yeah, it is a base of first metacarpal. Yes, Bennett's and Rolando both are intra-articular fractures. Both are base of first metacarpal. But how do you differentiate between Bennett's and Rolando? Yes, very good. Whenever I say it is a Rolando fracture, it is a comminuted fracture. So whenever it is a comminuted, then it is a Rolando fracture. When it is only two fracture fragments, then it is a Bennett's fracture. Bennett's is bi. Remember, B for bi. That means two fragments are present, right? So now these are the examples of it. Now what is this one? So this is the base of fifth. This is a Jones fracture, right? Base of the fifth metacarpal, which is a Jones fracture. And then what is this? This is a neck. Neck, second metatarsal. And if you see, there is some amount of callus also you can notice, right? So there is some amount of callus which is present here. So usually these people will come pain in the Bennett is an oblique fracture. Yeah. Rolando is a three-part fracture. Very good. So here what happens is in the neck, there is a second metatarsal, and usually what you see by the time the patient reaches you, there is some amount of callus also which is formed. So this is an example of a stress fracture. So stress fracture, second metatarsal. And now these two are your base of the first metacarpal. So one is your Bennett's. The second one is your Rolando. If you can see, the Rolando is a Y-shaped. So it is a comminuted fracture. But what you see, this is the Bennett's. It is just a Bennett's fracture, two fragments. But the longer fragment is having a tendon which is pulling down, which is called as the abductor pollicis longus, APL. So this is the tendon. Right? So this is pulling the larger fragment downwards, hence it disturbs the reduction. That is why what you have to do is, this is treated with absolute reduction. Absolute reduction, right? So because the pulling of the tendon, but this you can still go for a conservative treatment. So this still you can go for a conservative. That Rolando you can still go for conservative treatment because the comminuted fractures and fractures, the fragments are all near to it. But in case of Bennett's, what happened is because of their tendon pull, which tendon is pulling it downward? Proximally the pull is by the abductor pollicis longus muscle. So this muscle will pull the larger fragment downward. Hence you have to open it, then you have to correct it, and then you can fix it with the K wire. Right? So this is the Bennett's fracture. Very good. Very good. Now what is this? So this is actually an X-ray of a hand. And you can see there is some fracture in a little finger, fifth metacarpal. What is this fracture? Yes, very good. This is Boxer's fracture. Very good. It is not Jones. It is a Boxer's fracture. So Jones is in the metatarsal, that is foot. This is metacarpal. So these are the metacarpals. So the fifth metacarpal is neck is fractured. This is the Boxer's fracture. So this is your Boxer's fracture. Very good. Yeah. No question mark. You're right. This is Boxer's fracture. Right? So these are certain eponyms, and I will write the eponyms here. You're going to go back home and fill up all these eponyms, right? So the first one is your Colles fracture. So what is a Colles fracture? Then what is a Smith fracture? Barton's fracture, Malgagny's fracture, Duvernay's fracture, nightstick fracture. We are going to fill up all this. Right? Colles, Smith, Barton's, Malgagny, Duvernay's, nightstick. Then what is Potts? Cotton's, Chan's fracture, Clay Chevrolet's fracture, then Tellock's fracture. So now we are going back to home. I mean, maybe you're at your home. Now, after this class, you're going to write all the fracture names. So these are the various eponyms. Colles is dorsal fracture of the corticocancellous junction of what? Which area? Tophus. Then die punch. Then burst. So these are all various eponyms which you have to remember. Right? Right, hope you will all answer these questions. If you're not able to answer these questions, you can go for yesterday's YouTube session, Das Kadam. So in that I have discussed all the eponyms of the fractures, right? from the upper limb, lower limb, and the spine, which will be easy, and you can just go through before the exam also, right? Try to answer all these fractures. So Colles, I will just tell them orally, nothing to write. Once if you want to know them in detail, you can go back to that YouTube session. And forum, I forgot. Yeah, one very good. Monteggia and Galeazzi. These two are again very important, Monteggia and Galeazzi. So these are the fractures. So Colles is a distal radius fracture, dorsal displacement. Smith is a distal radius fracture, ventral displacement. Barton's is an intra-articular distal radius fracture. Malgagny's is a pelvic fracture where the ring is disturbed on the ipsilateral side. So anterior and posterior fractures on the same side. Duvernay's is an isolated iliac wing fracture. Then what is a nightstick fracture? Only isolated ulna is an ulna shaft is a nightstick fracture. Pots and cottons related to ankle. Bimalleolar fracture is pots. Trimalleolar fracture is cottons. What is a chance fracture? It is a fracture in the spine, which is a flexion distraction injury, which result in a horizontal fracture of the vertebral body, right? Horizontal fracture of the vertebral body. Claysh-Oberli's is spinous process fracture. Spinous process fracture of C6 or C7. Okay, what is a Tellox fracture? This is usually seen in children. And anterior tibulofibular ligament avulsion fracture, right, of distal tibia. And what is Chauffeur's fracture? Radial styloid fracture is your Chauffeur's. Dippunch fracture, again a distal radius fracture. Whenever you see involvement of the lunate fossa is a Dippunch fracture. Burst fracture is a vertical compression fracture of the spine where the body is completely burst, like it opens up. That is your burst fracture seen again in spine. Then Monteggia and Galeazzi, very, very important. Monteggia is fracture ulna with proximal radio-ulnar dislocation, and Galeazzi is fracture radius with distal radio-ulnar joint dislocation. Right, hope it is clear. Yes, so these are all the various fractures which you have to read. You know, all this might be asked as a one-liner or like this. They can put up a table like this and they can ask you as they match the following questions, right? Okay, now that is done. Now, what is this? A boy of 7 years old who was experienced trauma presents with fever and severe soreness across the thigh 2 months later. The femoral shaft might be seen on an X-ray as having lesions with many laminated periosteal responses. What level of management comes after that? So here problem is there was a trauma which was 2 months before. Now the patient is presenting with pain, fever, soreness in the thigh. Right, and now they have taken the X-ray and they have seen many multiple laminated periosteal responses. So now what you do? You go for a biopsy or you go for a MDP scan or you go for a CRP measurement because there is a fever and soreness. So what do you think this question is about? So here the answer is evident for you, but put up your a clinical thinking into it. So here the age of the boy is 7 years, right? And the one clue which we have here is the patient is having fever and soreness, that is nothing but pain in the thigh aspect, right? Thigh. And then what they're telling is there is a periosteal response. And this response is multiple laminated periosteal. So multiple laminated periosteal responses is nothing but your onion peel appearance. Your onion peel appearance, right? So if you see fever, the first thing what we think is osteomyelitis, right? But here what is the thing is whenever you see this age group with the fever, the one important thing which you have to put in your mind is this condition. So this is like multiple laminated responses. So this is onion peel appearance. So where you see this onion peel appearance, which condition gives you this onion peel appearance? Very good. It is Ewing's. So, as you got confused whether this could be osteomyelitis, yes, multiple responses sometimes can also be seen in osteomyelitis also. That is why what should be the management for this? You have to always go for a biopsy. This biopsy will confirm whether this is an infection or a tumor, right? So this is the final diagnosis, the final criteria where you can diagnose the condition. That is why in orthopedics, what you have to do is all the tissues should be sent for culture and biopsy, right? So all the biopsy things you have to send for culture also, and all the culture material you have to send for biopsy also, because the infection and tumor sometimes mimics, especially in this age group, in the age group of 8 to 10 years, right? Or 4 to 10 years. So this particular age group, you have to always be careful, because Ewing's sarcoma is one such condition which is usually seen in the first decade, and it appears usually in the diaphysis, and it produces onion peel appearance, that is multiple laminated periosteal reaction, and then this presents with fever, anemia, increased ESR rates. Right? You should not be confused between fever for osteomyelitis and Ewing's, right? So these are the conditions which we have to be very, very careful. So hence you have to send this for biopsy, right? And on the biopsy, what do you see for Ewing's? What type of a tumor it is? What type of a tumor is Ewing's? Kundan Singh, what type of tumor is Ewing's? It takes its origin from the PNET, right? Neuroectodermal tumor, right? And there are some translocations, that 12, 22, 11, 22 translocations, MIC 2 positive, CD 99 positive, all those you can remember regarding your Ewing's sarcoma. But from orthopedic point of view, please remember this always mimics infection, right? So whenever a patient is having fever, raised ESR with anemia, any doubt on the X-ray, please go for biopsy. Right? Please go for biopsy. Hence, biopsy is the one which confirms. On the biopsy, you see everything in blue color, right? So, all cells in blue color. Round blue cell appearance is in case of your Ewing's sarcoma, right? Moving on to the next one. A 65-year-old man with recent hearing loss has and right lower leg soreness and tenderness is present. The patient's skull seems like cotton wool X-ray. So this is asked in FMG, recent FMG, the cotton wool appearance of the skull, the most likely diagnosis. Here we have three conditions. So we have hearing loss, lower leg soreness and tenderness, and cotton wool in a old man, right? So these are all the clues for you. So what do you think is this condition? Is this a multiple myeloma or a Paget's or a thalassemia or fibrous dysplasia? Faster? Kundan Singh, do you think this is a multiple myeloma where you see cotton wool appearance on the X-ray? So the skull of multiple myeloma will present what? They present multiple lytic lesions, right? Or which is called as the punched out lesion. So we are ruling out multiple myeloma. Then Paget's disease, okay. Thalassemia, usually by 65 years old, thalassemia will be diagnosed, and you don't see cotton wool appearance on thalassemia or hearing loss. And fibrous dysplasia is also seen in the adolescent age group. So usually old individuals presenting with Paget's disease. So Paget's disease is a disease. It is all usually idiopathic, or it can be developed by a parvovirus infection or some genetic mutation. What happens is there will be lytic, sclerotic, phases. So there are two phases. One is lytic phase and second one is the sclerotic phase. On the sclerotic phase, what happens is there are bone formation which occurs. So there is a lot of bone formation which occurs. This bone completely closes and then there could be a hearing loss because of the sclerosis of the foramen. So because of the sclerosis which closes the foramen, which puts the pressure on the nerve, it will result in hearing loss. There will be cotton wool appearance, and there is a saying that the old hats no more fit, because all these are from the western world, what we take all the mnemonics. So the old hats no more fit, that means the head of the size increases because of the sclerosis, and whatever the man who was wearing his hat so would become a little size less, one size less for him. That means they don't fit them correctly enough. So because of the increase in the sclerosis, similarly because of that also there will be hearing problem to the patient. So that is the Paget's disease. Yeah, all this multiple myeloma, no. Screw cut. Yeah, in thalassemia you have this screw cut, right? And picture frame vertebra is also Paget's disease. That is again, picture frame is again sclerotic and lysis. So this is the Paget's disease where you see cotton wool appearance of the skull, and this is picture frame vertebrae, and this is ivory vertebrae, and this is garden frame. Garden blade appearance. So these are all the various features of this. So cotton wool appearance. Paget's disease, please remember, in old individuals. So there are two phases, sclerosis and lysis. This is the sclerosis. Cotton wool appearance, hearing is sclerosis, and ivory vertebra is sclerosis. The picture frame is also sclerosis, and the inside it is lysis. So that is the picture frame vertebra. And this is the garden. Again, this is a lytic lesion which is seen as the garden blade appearance. So these are all the features of your Paget's disease. Please remember, it is asked in the exam. Ivory vertebra is asked, cotton wool appearance is also asked. Right? Clear? Candle flame, not frame. Candle flame appearance or the garden blade appearance. Right? Then what is this? A, B. Faster, we have so much to learn. What is this? A is, yes, I think Kundan Singh, you can see what is this? This is the punched out lesion. So you can see these are various punched out lesions, right? So this punched out lesions is usually seen in multiple myeloma, especially in the skull. And what is this? Very, very important. Yes, fibrous dysplasia. That is your Shepherd-Crook deformity. Shepherd-Crook deformity, fibrous dysplasia. What is the one syndrome which is seen? This is not Langerhans histiocytosis. This is your multiple myeloma, punched out lesions. So Shepherd-Crook deformity is McCune-Albright syndrome. This was also asked in the NEET PG. What is McCune-Albright syndrome? Quick. Yeah, McCune-Albright syndrome, precocious puberty, cephalid spots, and then your polyostotic fibrous, right? So this is a fibrous dysplasia where it presents as ground glass appearance. This is ground glass appearance. Because the fibrous tissue is completely, the marrow is completely replaced by the fibrous tissue, it presents as a ground glass appearance, and this is known as a shepherd crook deformity because the bone gets deformed like this, right? And there is a condition which is called as a 𝐒𝐿-Bright syndrome, where you see the precocious puberty with cephaloid spots with the polyostotic, means multiple bones which is involved in fibrous dysplasia. Then what is Mesobrod syndrome? What is Mesobrod? Mesobrod is your intramuscular myxomas with fibrous dysplasia, right? Myxomas with fibrous dysplasia. Intramuscular myxomas with fibrous dysplasia is your Mesobrod syndrome. Hope we got the answer for this. The answer is Paget's disease, right? Moving on to the next one, the patient presented with the following deformity depicted in the image. The nerve damage in this deformity will be radial, musculocutaneous, median, and the ulnar nerve. Very, very easy, I guess. Yes, the answer here is already written here. This is called as the partial claw hand. So this is called as the partial claw hand, where you see there is a clawing of only the medial fingers, and these two medial finger flexors are supplied by the ulnar nerve, and this is called as the ulnar nerve palsy. This is called as the ulnar nerve. Hope, I wish everybody of you are very, very familiar with this topic of nerve injuries. Very, very important. 3 important nerves which you have to read is the radial nerve injury, then we have the median nerve injury, and then we have the ulnar nerve injury, right? So this is actually I've put up in my Instagram, Dr. Alekhya Ortho. So the same images I have bought here, which will be easy for you to revise, right? So this is radial nerve injury. In the radial nerve injury, the most important thing is the radial nerve supplies all the extensors. It supplies all the extensors, and on the extensors, what happens is, one important thing which you have to remember is the Saturday night palsy. The Saturday night palsy, and one more important thing is Holstein-Lewis fracture. So Holstein-Lewis fracture and Saturday night palsies. So these two are very, very important conditions related to the radial nerve injury. And usually we don't have any test for radial nerve. What you see, this important condition which is called as the wrist drop. In the wrist drop, this is called as the wrist drop, and in the wrist drop what you see is this wrist drop usually occurs because of the damage to the radial nerve above the elbow, right? If it is below the elbow, this is called as the finger drop, and this finger drop is because of damage to the posterior interosseous nerve. So pin nerve is resulting in pin drop. This is below the elbow, and wrist drop is above the elbow, right? And how do you treat the radial nerve palsy? The treatment is cock-up splint, which is of 2 types, the dynamic cock-up splint, and there is a static cock-up splint, right? If not, it is not getting corrected after 6 months, then you go for tendon transfer, right? You go for tendon, right? So is that okay? Are you following? Are you with me? Kundan, Shivani, Yashasvi, Navodit, Komal. Come back. So this is about your radial nerve injury, right? And then what is this? The next one comes to your medial nerve. Medial nerve supplies the flexors, right? They supply the flexors. So these flexors are all the flexors it supplies except the flexor digitorum profundus medial half and your flexor carpi ulnaris. These two are not supplied by the median nerve. Rest all the flexors are supplied by your median nerve. Very good. So, Shivani, Yashasvi, thank you for your reply. So, median nerve is by the flexors, FTP, except the flexor digitorum profundus, the medial half, and the flexor carpi ulnaris. All the long flexors are supplied by your median nerve. And coming to the hand, they supply the thenar muscle. So they supply the thenar muscles, right? And here also in the thenar muscle, one exception is your adductor pollicis. So this adductor pollicis is an exception again, which is supplied by your ulnar nerve. Now remember, it is very easy for the median nerve. Just remember the thumb, the index, and the middle finger. These three will denote the median nerve. These two will denote your ulnar nerve. And something dropping like this is your radial nerve. That's it. So if there on the image, if something is related to your median nerve, like the benediction is related to median nerve, index ring finger. So this is median nerve, right? And something related to your ape thumb deformity, something related to thumb is your median nerve. Pointing index, something related to the index is median nerve, because these three fingers are supplied by the median nerve. These two fingers are supplied by the ulnar nerve. That's it. End. No need of by hearting, no need of putting mnemonics, no need of remembering so much into your brain. Just see on the picture. If they are talking something related to your thumb, the index or the middle, simply mark the answer as the median nerve. If they're talking about these two fingers, your middle finger and the little finger, put the answer as the ulnar. If not, finger flexors are involved, if extensions are involved, then it is up to your radial nerve. That's it, right? And now, so for completion's sake, let us learn what is this median nerve test. So first is your ape thumb deformity. So usually the apes are one which have their thumb. They also have 5 fingers, but they are in line like this, right? But for the mammals, especially for the human beings, there is an evolution of the thumb which is perpendicular to the palm for various pinch, grasp, and various other activities. So this again going back in line with other fingers is the ape thumb deformity. Then benediction or the Pope's sign. So whenever you do this cross, the Pope, or these are called the most honored profession, or most honored people in Christianity, they do this benediction sign. So this is called the Pope's sign. So what happens here? You do a fist like this, but because the flexors of this are weak, it just your hand will become like this. It will be in this position, which is called the benediction. And again, one more thing, what you can do is whenever you're doing this Oshner's classic deformity, or whenever you're trying to pray again like this one will stand outstanding to others. This is called as the pointing index. Why? Because this is exclusive. The flexors exclusively are supplied by your median nerve. And then again the pen test. So pen test, remember, it is with your thumb, right? So that is why it is related to median nerve. But book test is related to your ulnar nerve, right? And then 𝐒𝐿 sign or the O sign. Similarly, I have told you the pin, the posterior introosseous nerve, is related to your finger drop. Here in the median nerve, the branch of the anterior introosseous nerve is related to your 𝐒𝐿 sign or the O sign. If this O is perfect like this, then it is and that is your anterior introosseous nerve is intact. If it is something like this, there is no O sign, it is something like oval, then there is a palsy of your anterior interosseous nerve. That is about your median nerve, right? And now moving back to your ulnar nerve. So ulnar nerve, very, very important, as we all know that this is applied the flexors, that is your flexor digitorum profundus and the flexor carpi ulnaris. So these two are the flexor which are supplied by the ulnar nerve. And remember something I told you related to these two fingers, right? So here what is main thing is in the hand, it is supplying the hypothenar muscles, and it supplies your third and fourth lumbricals, and it supplies your dorsal interossei muscle, the palmar interossei muscle, and then it also supply your adductor pollicis. So this is the complete supply of the ulnar nerve. So once you know that the dorsal interossei and palmar interossei are supplied by the ulnar nerve, when you go back to your anatomy, you can remember this pad and dab, right? So this is the abduction and adduction. So this is done by the card test. So you have to remember the card test is by your ulnar nerve. That is adduction and abduction. So abduction is 𝐒𝐿. Abduction, 𝐒𝐿. Adduction is your card test. And then you already know that the partial claw hand is nothing but nerve palsy. And one more thing, I have told you the book test, because see, if somebody is asking you to hold this, imagine this as your book, and somebody is asking to hold the book like this, right? You try to hold the book like this, but there is an ulnar nerve, adductor pollicis. So this is called the adduction. And now you want to hold it. We will never give up, right? We always will try. We compensate. Body always tries to compensate. Like if you remember the hip flexion, there it is compensated by your spine. So here, what does it do? The adductor is weak. Now, what comes to your rescue is your flexor. Flexor pollicis brevis, which is active, will tell, I will take care of this book now. And now, whenever the flexor is active, it tries to flex the interpharyngeal joint. So this is called the Froment's sign. So whenever there is a flexion happening instead of adduction, this is called as the Froment's sign, and this is seen in the book test and usually an indication of ulnar nerve palsy where the adductor pollicis is paralyzed, right? So that is it about your various nerve, especially the upper limb nerves. Very, very, very important, right? And maybe the Erb's palsy and the 𝐒𝐿𝐴's palsy is also important. What you have to remember is, if you remember the anatomy, it will be very, very easy. The Erb's palsy is the upper trunk, right? So in the upper trunk, what happens is it is supplied by the supraspinatus, right? So the supraspinatus is mainly responsible for the abduction. Now, loss of abduction will result in adduction, right? So the flexors are lost there. And again, what happens is the musculocutaneous, which is responsible for the flexion, is lost. Now, this will result in extension. So, there will be adduction, internal rotation, extension and pronation, which will result in policeman tip deformity because of your upper trunk, that is C5 and C6. C. Right? Please remember abduction and musculocutaneous nerve, where it results in the deformity, adduction and extension at the elbow, internal rotation and pronation, which will result in what is called as your police tip deformity or waiter tip deformity in case of your Erb's palsy. Right? Then what is 𝐒𝐿𝐴's palsy? 𝐒𝐿𝐴's palsy is injury to the lower trunk where C8 and T1. As we all know, C8 and T1 plays an important role in formation of the ulnar nerve. You see what is called as the claw, right? So here there might be involvement of median nerve as well. So sometimes you will experience a complete claw hand, and if this particular T1 is involved, then this may also result in Horner's syndrome. So what is that Horner's syndrome? It is given on the screen, where the patient will have anhidrosis, ptosis and meiosis, right? So affected side, you can see anhidrosis, lot of sweating, loss of sweat. Loss of sweating. Ptosis is drooping of the shoulder. Meiosis is pupil constriction, right? So this is all seen on the affected side whenever the root T1 is involved in case of your Horner's syndrome, and this is called your 𝐒𝐿𝐴's palsy, right? Hope you all understood. Okay, good. That would be a great revision for you, right? So now let's go back to the classification, the Hawkins classification. Yes, thank you so much. Now, what is this? Hawkins classification for which bone fracture? This is again a NEET question, last year NEET. Hawkins is for which bone? I have given the answer already. The talus, tibia, humerus, calcaneum. So the answer is given already. So it is a talus neck fracture. So now tell me, what is the fracture proximal humerus classification name? Proximal humerus classification. So I have told you that Hawkins is a classification name which is given for talar neck fractures. Now tell me, the proximal humerus fracture is classified based upon which classification? Very good. It is Neer's classification. Very good. It is Neer classification for proximal humerus, where it is divided into 4 parts: the greater tuberosity, the lesser tuberosity, the head and the shaft. So that is the classification. And proximal tibia? Proximal tibia? The name of the classification for proximal tibia? Faster. Yes, very good. It is a Shadgar's classification. It is a Shadgar's classification. Then calcaneum. So now calcaneum has 2 fractures. One is the X-ray classification. The second one is the CT scan classification. So if you remember, one is enough, I think. So what is the CT scan? Yeah, proximal tibial is Shadgar. Very good. Then the calcaneum. Yes, CT scan, it is the Sanders classification. X-ray, it is Essex-Lopresti classification. Okay, now we have finished a few of them. So let us read everything. So first is your proximal humerus. It is the needs classification, right? Then coming to the Montagia classification, radial head, supracondylar humerus fracture, acetabulum, pelvis, fracture head of femur, neck of femur, and then your we have finished the talus, calcaneum. Yeah, we have finished, right? So now what is proximal humerus also we finished. Then Montagia, yes, it is Bedo, not Boyd. Next, radial head, it is Mason, right? Yeah, very good. It is Bedo for Montagia. Then supracondylar humerus fracture. Yes, Mason for radial head. Then supracondylar humerus. Gartland. It is very important. Then acetabulum, lateral and Judet. Pelvis, style 1. The second one is Young and Burgess classification. Right? And then fracture head is Pipkins. Please read it carefully. Head is Pipkins, right? And fracture neck, again we have two. So one is Gardens. Second one is your Powell's, right? Then we finished Talus, right? This is Hawkins, Sanders, and the Schatzker. These are the various classifications which you have to remember. A 45-year-old diabetic male with history of roadside accident 1 year back presents with pain and swelling in the forehead. With discharging sinus, X-ray is given below. What is the most probable diagnosis? So this is the X-ray of the femur, right? It was by mistake forearm was given. So what is the most probable diagnosis here? What do you see? What the X-ray tells you? Yes, very good. It is the chronic osteomyelitis. So why it is a chronic osteomyelitis? Because what you can see on the X-ray, you can see what is called as the sequestrum. Yes, what is a sequestrum? Sequestrum is a dense bone surrounded by lucency. So can you tell me why it is dense? So it is a dead piece of bone. So why do you think the dead piece is a dense bone? Why is a dead piece a dense bone? Did you ever think of it? Why it is dead? It is dead because there is a lack of blood supply, right? The blood supply is cut off to that particular bone, hence it has become dead. Then why it is looking sclerotic? Why is this sclerotic? Dead bone, sequestrum. Okay. Why it is a dense bone? So I know you all have identified this as the sequestrum, right? So this is a dense looking bone which is surrounded by a layer of lucency. So we all know that the lucency is nothing but your granulation tissue which is not seen on the X-ray as the lucency. Now why the bone is dead? Yeah, it is loss of blood supply, it is dead. Why it is appearing dense now? Anything which doesn't have blood supply will appear dense. And yes, the answer is yes. Anything which doesn't have blood supply will appear dense because the phenomenon of the bone dynamics. The phenomenon of the bone dynamic is that anything which is active is lucent. Anything which is dead is sclerotic. Right? Sclerotic means there is loss of resorption in that particular bone. So if you go back to the bone metabolism, what happens is first there will be bone formation, then there will be resorption, and again there will be formation, right? So here in the dead bone, this resorption is absent. Hence, this appears sclerotic, right? So this appears sclerotic because of the blood supply which is cut off. Yeah, because not able to demineralize because of no blood supply. Yes, no bone resorption. Very good. So all the answers are right. So because of this lack of bone resorption which is not occurring in the, because blood resorption occurs whenever there is a blood supply to it. There is no blood supply to it, right? So because of there is no blood supply, there is no action of that resorption here. Hence it appears as a dead bone, sclerotic dead bone, right? And now this is surrounded by the lucency. This lucency is nothing but the granulation tissue. So this is lucency indicating the granulation tissue. This is all the feature. Whenever you see a sinus, discharging sinus is a feature of the chronic osteomyelitis. That means there is an infection which is present inside the body where the body defense mechanism cannot control it. Hence, it spreads from the bone to the soft tissue and then it breaks out onto the skin as the sinus, right? So, whenever you see a sinus which is discharging bony specules, that is the dead bone pieces, which is called as the sequestrum. And what is the new bone which is called as? The new bone is called as the formation of the new bone is called as the involucrum, and the openings is called as the cloaca, right? So here the new bone which is formed is called as the involucrum. The openings are called as the cloaca, right? So that is how the osteomyelitis is dealt with, right? So here the answer is the chronic osteomyelitis. Then what is acute osteomyelitis X-ray features? Do you see anything on the X-ray with acute osteomyelitis? Usually acute osteomyelitis, the first 24 hours nothing is seen. The next 48 hours also nothing is seen, and slight changes can be seen in 72 hours. Not very relevant. Okay, so acute osteomyelitis, nothing can be seen, right? What is Gary's sclerosing osteomyelitis or Brody's abscess? What are these two? So I have told you that, so what is actually osteomyelitis? So whenever we talk about the osteomyelitis, this could be acute. That means a condition which is less than 2 weeks, or this could be chronic, which is more than 2 weeks, right? So in acute, the patient usually presents with fever, raised ESR, ERP, pain, right? And X-ray features not very specific, right? And treatment, you treat it with 2 weeks of IV antibiotics plus 4 weeks of oral antibiotics, right? So this is how you treat it. In immunocompetent individuals, is there localization of the abscess? Yes, that is Brody's abscess. Then what is chronic? Chronic is where the patient is having an acute osteomyelitis which was not treated properly, right? And because of the low immune status, the infection proliferates, infection multiplies, and then it will result in sequestrum, cloacae, and then it opens up in as this. So here chronic osteomyelitis, it is surgical management. Right, in chronic osteomyelitis, it is surgical management. So in between this acute and chronic, there are two things which is called as the subacute. That means the immune status is good So there will be localization of infection, which is called as the Brodie's abscess, right? That is your Brodie's abscess. So this is about the Brodie's abscess. So you can see there is localization of that particular infection over that space. Sometimes this can be confused with the tumor, right? Hence, you have to be very careful while dealing with the infections and the tumor, right? So that is the Brodie's abscess. So this is your Brodie's abscess. And what is sclerosing osteomyelitis? This is also a type of infection where there will be sclerosis which is seen. So this is also a type of subacute infection. This is where you see multiple layers, or again you can be confused with this, your Ewing's sarcoma, right? So these two are examples of the subacute osteomyelitis, and the extreme ends are the acute osteomyelitis, and this end it is the chronic osteomyelitis. So what is the surgical treatment you do, which is called as the saucerization, right? So that is about the infections. Clear, everybody? Any doubts regarding the infections? So the most common thing whenever they ask you the organism is again your, please mark it as staph. Yes, staph aureus. Most common is staph aureus. Don't feel that this is very easy. Why will they ask such questions in NEET PG and all? Whenever you see what is the most common organism involved in infections of bone, it is staph aureus. Yes, right? Next, a patient came to the OPD with a pain near wrist joint. After examination, tenderness was found to be at 5 centimeters from the wrist joint over the dorsoradial forearm. Pain made worse with the resisted wrist extension and thumb extensions. So whenever there is a wrist extension and thumb extension, the pain was worse. What is the most probable diagnosis? This is the area where you have to read the question very, very properly. You will get tempted to attempt the answer as the 𝐑𝐄𝐝 stenosynovitis. But once again, if you read the question, you will be even more familiar with the answer. Can somebody answer this quick? So this is the tendency of us. So if you read something and if we remember, we feel that that would be always the answer. We'll not try to read it clearly. So for it, this answer to be 𝐑𝐄𝐝 stenosynovitis, where the pain should be. What is actually 𝐑𝐄𝐝 stenosynovitis? It is the condition where the involvement of the first extensor compartment. So what are the tendons of the first extensor compartment? They are APL and EPB, right? These two tendons should be involved to tell that as a 𝐑𝐄𝐝 stenosynovitis. So where the pain will be in case of 𝐑𝐄𝐝, this is the tendon, right? This area is usually painful. But what did they clearly mention? They mentioned that it is 5 centimeters from the wrist joints. So from here, it is 5 centimeters somewhere here, right? Infection, carpal tunnel is median nerve. No, median nerve is for flexing. Ulnar nerve trapment is wrong. Again for flexors, carpal tunnel is wrong. It could be extension or intersection or 𝐑𝐄𝐝. 𝐑𝐄𝐝, I've told you that it is APL EPB. So the answer is intersection syndrome. So answer is A. Very good. Nischay, yes. A is the answer. It is the intersection syndrome. So not always the answer would be 𝐑𝐄𝐝 stenosynovitis. So if you see, this is the condition. So this is the first compartment tendons. So these are APL and EPB, where the tendon sheath gets inflamed. So this is the tendon sheath. This is the tendon sheath which gets inflamed, and on extension, resisted extension, you will have pain. So this is the test which is used to detect this 𝐑𝐄𝐝 stenosynovitis. And the pain, if you see, it is exactly near the wrist joint, right? It is exactly near the wrist joint. So what is this test? Janvi Rajput is also right. It is A. So this is the Finkelstein's test, right? It is Finkelstein's test. Now, what is this? Then what is the intersection syndrome? Intersection syndrome is the area where the first and the second compartment tendons intersect. So this second compartment, what are those second compartment tendons? There are 6 compartments, right? The first compartment is APL EPB. Second compartment is extensor carpi radialis longus, extensor carpi radialis brevis. So there is an area in the forearm on the dorsal aspect. If you see again, it was mentioned that it is the dorsoradial forearm. Dorsoradial forearm meaning the dorsal aspect here, somewhere here. So this is the area where the tendons intersect. So the APL EPB will cross the extensor ECRB and ECRL, and it will form as the first compartment. So that is called the intersection area where the pain is present. So this is called as the intersection syndrome, right? So this is how you have to be very careful in answering the question, right? So you have to always think twice. You have to eliminate and then come to a conclusion. So whenever they say 𝐷-𝐄𝐝, it should be near the wrist, right? So they have clearly mentioned that it is 5 centimeters away and in the dorsoradial forearm area, right? Now, what are the various tests which are used for the carpal tunnel syndrome? So, what is carpal tunnel syndrome? Carpal tunnel is mainly for the compression of the median nerve. Median nerve is carpal tunnel. So, this median nerve compression can be done with various maneuvers. The one important one is the direct carpal compression test, which is also called as the Durkan's test. So, this is also called as the Durkan's test. Very good. Very, very important. And it is most specific. It is most specific. And then what is this? This is Fallon sign, reverse Fallon sign, Tinel sign. These are all the examples of your carpal tunnel syndrome. So if you see everything, there is a compression of the wrist. So whenever there is compression of the wrist, the volume of the carpal tunnel decreases. So the volume of the carpal tunnel decreases. So when there is a decrease in the volume of the carpal tunnel, which results in the median nerve palsy, which results in what is called as median nerve palsy. So this is the Fallon sign. Again, wrist extension, wrist is in flexion, and reverse Fallon sign, again you put the wrist in flexion like this. So whenever there is this wrist flexion occurring, there will be compression of the median, right? And what is the most specific one? The specific one is the Durkan's test, that is direct carpal compression test. So you directly compress on the carpal tunnel, right? So this is about your carpal tunnel syndrome. Then what is this? So I think this condition, just as you see the image, you can answer. So this is nothing but your Dupuytren's contracture. So what is your Dupuytren's contracture? So this is nothing but the palmar fascia. So this is a myeloproliferative disorder. Myeloproliferative means there is a proliferation of the fibrous tissue which is present, and it forms like a cord-like structure. This cord will cause the flexion contracture. This will cause the flexion contracture, and especially it is seen in the ring finger, as you see this figure, right? Usually seen in the ring finger and also the little finger, right? So this is a myeloproliferative disorder of the palmar fascia. And what mainly seen in the males. It is most commonly seen in the males, it is most commonly seen in alcoholics, and it is most commonly seen in liver cirrhosis. And it is also associated with the other conditions like the Peyronie's disease of penis and Lederhaus disease. Similarly, the same fascia. This is the penile fascia, and this is your plantar fascia. Understood? So this is the Dupuytren's contracture. What you have to remember is mainly seen in case of the males. So the more common in females is something which is wrong, and usually the trauma of chronic repetitive is most common cause. So they will be always, irritating that palmar fascia. This irritation of the palmar fascia will causes proliferation of the fibrous tissue. right? And this proliferating fibroplasia of the farmer tissue is nothing but the pathology of this condition. And usually we give steroids. So intralesional steroids are usually given, but or fasciectomy is the best treatment. Surgery is the best treatment. That is the fasciectomy. Removal of that fascia is the best treatment. So surgery is the best treatment, and trauma is one of the main cause, and it is a proliferating farmer tissue. So the answer here is it is more common in female. What they have asked is false, right? So that is why that is the answer. And then what is this? What is this condition? So you will see some nodule at the junction of the tendon and the tendon sheath. Then this is called as what? Yes, very good, Shivani. This is the trigger finger. Why do you call this as a trigger finger? So this is a condition where we see there is this, if you see, this is the tendon, right? So this tendon happily should move in this tendon sheath. So this is the tendon sheath, right? So you can see there are some into marks on it and some band-like things like that. These are called A1 pulley. This is called C1 pulley. Cruciate. This is called cruciate for C. This is called annular for A. Right? And now what happens is this flexor tendons should move inside this flexor tendon sheaths. So as there is some problem in the movement of this flexor tendon in the tendon sheath, this could be because of again the irritation which we are causing, the activities which we do, and because of this nodule, whenever you try to move that nodule inside the tendon sheath, it produces a snapping sound, and this is called as the trigger finger. So here also what you do, you repair this, you remove this nodule, but you will try to preserve this A1 pulley, which is very important at the MCP joint. So if you see this is the A1 pulley here. So near the MCP joint is the A1 pulley. So you should not damage that A1 pulley, otherwise it will be very difficult to repair it, and without damaging that you will remove the nodule. So this is the trigger finger. Again, you can use a dose of steroid injection also for treating it. So this is the trigger finger. And then what is this? So this is a gamekeeper's thumb. What is a gamekeeper's thumb? What is that structure which is damaged in a gamekeeper's thumb? It is the ulnar collateral ligament, right? It is the ulnar collateral ligament, UCL. And where it occurs, it is usually seen in hyperabduction injuries of thumb. Whenever there is an hyperabduction injury of the thumb, usually the gamekeepers, they usually hyperabduct the thumb, and they will result in damage to the ulnar collateral ligament. Usually this will heal, but whenever there is this adductor pollicis which is coming between, then this is called as what? It is called as the Steiner's lesion. Steiner's lesion is this adductor pollicis which is attached to this tendon will come between the UCL torn ligament. So this ligament will get torn, right? So this adductor pollicis will come in between, and it will help and it will usually hinder the process of healing. So whenever you see this adductor pollicis which is coming in between, then that is called as the Steiner's lesion. So that is called as the Steiner's lesion, right? Next question. A 30-year-old HIV patient with right hip pain presents with night sweats and weight loss for the past month. On examination, there was a deformity, that is flexion deformity, abduction, and external rotation. What would be the most likely cause? Right? So we already know that the tuberculosis of the hip. So it is very important topic. Again, the tuberculosis of the hip joint. It is into 4 stages, right? The first stage is stage of synovitis. Second stage of early arthritis. Third stage of late arthritis. Fourth stage of advanced arthritis. Very important. Usually they will ask you. So here what happens is whenever there is a stage of synovitis, what happens is whenever there is an inflammation of the synovium, the joint usually takes the maximum volume position. So this maximum volume is, it should accommodate the synovial fluid. Synovitis is inflammation of the synovium which produces more of synovial fluid. The main function of synovium is to produce synovial fluid. Now you keep on irritating synovium, it keeps on producing more fluid. So whenever there is more fluid, the joint takes its position to accommodate this fluid, which is flexion, abduction and external rotation for hip joint, sorry, and flexion for the knee joint. So this is the most accommodating position of the hip, that is flexion, abduction and external. So once the synovium fluid has been resorbed, that the synovitis stage has gone, and now what happens is there is a damage to the tissue inside the joint, which is resulting in arthritis. Arthritis is inflammation of the joint. Synovial inflammation is done. Now the joint structures has been damaged, resulting in arthritis. Now it goes into flexion, adduction and internal rotation. And from here it is flexion, adduction and internal rotation. And this advanced arthritis, there are two important things you have to remember. One is your wandering acetabulum, and the second one is your motor and pestle appearance. Right, so this is the stage of synovitis, stage of early arthritis, stage of late arthritis and stage of advanced arthritis. So one is your wandering acetabulum and one is your motor pestle appearance. So here this is the wandering acetabulum. So what is actually the wandering acetabulum? So what happens is the acetabulum is completely damaged and this head keeps moving up and down because the acetabulum is so wide and now head moves up and down. So it keeps, so that is called the wandering acetabulum, or the lower of that would be empty. That is lower acetabulum. And next, motor and pestle is, if you go back to olden days or if you go back to your kitchen, when there is something like this, right? Mortar and pestle. So you put these things and you grind them into powder, like your cloves or cardamom, cinnamon, all those you put and ground into the powder. So this is called the mortar and pestle, and this type of appearance. So this acetabulum is acting like this, and now this whatever the head has become in this shape will give you this appearance of your mortar and pestle appearance. Right. So these two are the advanced features in case of TB hip arthritis. Right, and now in case of your stage 1, if you see, you can see that there is some lengthening which you can see, right? So the leg appears long, but this is just appearing, so it is called an apparent lengthening, not true. It is just appearing to be. And here you see in the second stage the length appears to be shortened, so this is also an apparent shortening, appears to be. And now in the stage 3, it is a true shortening. It is a true shortening. So these things you have to remember: the Faber, the apparent lengthening, apparent shortening and true shortening in 3 stages. And in advance, it is wandering acetabulum and motor pestle appearance. Clear? I want an S from everybody. So now we have, and one more thing, whenever they tell you something related to HIV patient, HIV and TB is always in relation. So there are good friends. So whenever you see an HIV patient, you should always first put the diagnosis as tuberculosis. Okay. So here we have given, they have given us a very big clue that it is a HIV patient and there is night sweats and weight loss. So in TB also you will see night sweats and weight loss. And now the joint deformity is flexion, abduction and rotation. It cannot be avascular necrosis because Faber is never seen in avascular necrosis. It should be tuberculosis or transient synovitis. But in HIV patient with the night sweats and with the weight loss, this is not the answer. The transient synovitis is a condition where there will be minimum infection which with the Faber presentation. Minimum infection with Faber presentation. It is usually seen in children, right? And septic arthritis, again, it could be septic arthritis, but night sweats and weight loss and HIV patient, again we are putting the answer as tuberculosis. So that is how I have answered this as answer B, that is tuberculosis. Fine. So that is how you have to conclude. I mean, like, you have to always come with the elimination of the options. That is how you can reduce the, simple mistakes. Like, for example, between septic arthritis and tuberculosis. So septic arthritis patient will with severe pain and usually it is usually seen again in children, right? But whenever you see an HIV patient with night sweats, with weight loss, and with this Faber stage 1, usually think about tuberculosis. So that is how you have to think. Father should be preferred in TB hip presentation. Yeah, the problem is in Faber, usually whenever they come in Faber, no, they come in the second stage. Usually in Faber, they try to neglect because it doesn't give them pain. TB is something which is very chronic infection. So diagnosis of the TB in first 2 stages is very rare. Here the patient has come because only he is HIV patient, right? Because he's already immunocompromised because of this TB, he has come in the stage 1. Otherwise, if you want to diagnose this patient, this TB particular patient, usually they will come in the end of stage 3 or stage 4. It is very, very slow disease. TB is very slow disease. That is why usually we see father. But in this condition, because he is already immunocompromised with the HIV, probably he can come with Faber also. Fine? Convincing? Yashasvi, yeah, you are right, because whenever they give you questions like Faber, no, you have to always opt for septic or trans and synovitis, but depending upon the question, that is why you have to put that scenario correctly there. So here I've told you the HIV plays a very important role, and they've given clue of night sweats and weight loss. So there it would go with the TB presentation. Okay, because now you are all PW students, so you will mark TB even if they don't give father also. Right? Okay, now the next question. A 74-year-old man presented with low back pain that was radiating to his legs. On examination of the spine, a palpable step was felt in the lumbosacral region. What is the likely diagnosis? So here there is a 74-year-old man and there is a low back pain and there is a radiating to legs. So whenever there is a low back pain which is radiating to legs, it is an indication of sciatica. Sciatica is not a disease, it is a symptom, right? So now we had got a symptom which is sciatica, and on the examination we have felt that good for Yashasvi. She is more he or she Yashasvi is more convinced with Nishchay's response. That is why. Okay, thank you, Nischay, for that. So now getting back to our question, on examination of the spine, a palpable step was felt. So whenever you see this palpable step, so this is called the step sign. So when you see this step sign is mostly seen in, what is spondylolysis? Lysis is break in the pars interarticularis. That is lysis. Listhesis is forward movement of the vertebrae. Okay, then disc bulge and vertebral fracture. So the step sign usually in the patient who is coming to the OPD, vertebral fracture is something related to trauma again. So you have to be careful in the traumatic cases. But here the patient has come to the OPD and now with low back pain and you can see a step sign. So the answer here undoubtedly is spondylolisthesis, because step sign is a feature of spondylolisthesis. Now what is spondylolisthesis? Spondylolisthesis is this. Now if you see, this is your vertebrae, 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 and vertebrae. If you see, there is forward protrusion of this is L5, L4, L3. So there is L3, L4 spondylolisthesis. Listhesis is again movement or forward protrusion of the vertebra, upper vertebra compared to the lower vertebrae. Right, so you have to always draw a line not on the anterior aspect but on the posterior aspect. So whenever you palpate this spinous process, because of this movement, there is one step sign. So one spine will be inside and this next one will be outside. For that, when you palpate it on the examination, you will find this step sign. So this is spondylolisthesis. What is the classification name for spondylolisthesis? This is called as Meyerding classification and it is in relation to the vertebra. So you will draw a line on the vertebra like this and divide into 1, 2, 3, 4 and 5. So every 25% is 1, 50, 75, 100. And completely it is falling like this, then it is spondyloptosis. Right? If it is only 25% of the movement, it is between 1. 50, it is more than 50, it is grade 2 or 3. It is never 1, 2, 3, 4. You should always tell it as grade 1 or 2, 2 or 3, 3 or 4, 4 or 5. If it is completely falling forward, then this is called as spondyloptosis. Right? So the Mayerding classification has given this type 1, type 2, type 3 and type 4. And there is a step sign which is seen in spondylolisthesis. And what is this? This has been asked in the exam again. Guys, come on, answer. What is this? Yes, very good. This is shopping cart sign. So this is called the shopping cart sign. So where do you see, which condition you see the shopping cart sign? Very, very important. This was asked in the exam. Where do you see the shopping cart sign? Which condition? It is usually seen in the what is this? Lumbar canal stenosis. So what happens in lumbar canal stenosis? So you imagine that this is a canal. So this is the canal around, and from here the nerves are passing through the canal. And now whenever there is a reduction of this volume of the canal, there will be pressure occurring over those nerves and they will produce the sciatica. That is, they cause pain inside the back, and then this pain radiates along the legs. So that is the sciatica. Now why this occurs? Why is the shopping cart sign very specific for your lumbar canal stenosis? So this canal becomes narrow whenever the patient extends. Right? So whenever you're extending, whenever you're standing straight, the narrow is more, the canal becomes more narrowed. That means the signs and symptoms will increase. But now once we flex, the canal opens. That means the volume of the canal increases, hence the signs and symptoms will decrease. So the patient will always find the flexion of the spine comfortable position. So the shopping cart is usually how you push the shopping cart. You push the shopping cart by flexion, right? So that is why the pain is relieved. So this is called as the shopping cart sign. And there is one more thing what you have to remember is going uphill. So now I have explained you this, right? So which causes more pain, uphill or downhill? So uphill or downhill is when patient is moving uphill. If is moving upwards the hill like that, or is coming downwards the hill, which is more painful. So imagine you're climbing or moving up a ramp. So whenever you try to move up a ramp, do you bend and move, or do you extend and move? Yes, Shivani is right. Moving uphill is painful. Whenever you're trying to move downhill, you try to bend, right? So pain is more in uphill, less in downhill. Right? So nothing. The concept is simple. Extension, painful. Flexion, pain-free. So just imagine yourself, or Nishya, you try walking downhill today. Do you walk like this or do you walk like this? So uphill usually we try to extend. When compared to downhill, uphill we usually try to extend, right? So that is how the pain is more in case of your uphill, and in case of your downhill it is little less because of the flexion, right? So this is an MRI of lumbar spine. Right, this is an MRI of the lumbar spine. And now, so yeah, Shivani, this is lumbar canal stenosis. That is fine. But what exactly is the reason for this lumbar canal stenosis? So just allow me to name it. So always start with the sacrum. So this is the sacral S1. This is L5, L4, L3. Right? So here what happened is, between the L5 and S1 there is a disc. And if you see, the disc has bulged out, right? And this disc is compressing the nerves on the posterior aspect. So this is nothing but an example of prolapsed intervertebral disc, which is resulting in lumbar canal stenosis, right? Lumbar canal stenosis. So PIBD with lumbar canal stenosis. Okay. So this is called the disc bulge. Yes, L5S1 disc prolapse. Very good. Then what is this? This is scoliosis. This is scoliosis. What is scoliosis? It is nothing but we are sideward bending. So this is one which is bending, right? The S-shaped curve. This is the sideward bending, the scoliosis. And what is the angle which is measured here in the scoliosis? This is called as the Cobb's angle. It is asked in the exam again, exam based question this is. So how do you do the Cobb's angle? You have to take the whichever the sideward bending, the particular thing, you know. Again, this is a little complex topic where you have primary curves, secondary curves and all. So you have to always take the primary curve, and this curve, for example, let us think this is the primary curve, and now in this curve what you do is you have to identify this vertebrae, you know, the last vertebrae, the end vertebrae this is called. So this is the end vertebrae and this is the end vertebrae. So you have to draw a parallel lines over the upper upper part of the vertebra and here the lower part of the vertebra. These are called the end plates. So upper end plates and the lower end plates, and now you draw perpendiculars to these lines, these two lines, and now this is called your Cobb's angle, right? What is the importance of this Cobb's angle? It should always be less than 20 degrees. You go for observation, right? If it is 20 to 40 degrees, take the help of braces. So what are the two braces which are used? One is called the Boston brace. The second one is called the Milwaukee brace. And if it is more than 40 degrees, go for surgery. Right? So this is how the Cobb's angle is useful. And what is the research sign? Research sign is you have to take the help of the skeletal maturity for deciding for this surgery, right? Skeletal maturity. Once the skeleton is matured, then you have to plan for surgery. So how will you know that the skeleton is matured? You take the help of the iliac apophysis. What is apophysis? So epiphysis is one which is present near the bone. This is the bone. So this is your epiphysis, right? Between your metaphysis. This is the meta and this is your epi. This is the physis. So this will increase the length of the bone. Then what is the apophysis? Apophysis will increase the circumference of the bone. So that is your apophysis. So whenever you see, take the example of this iliac apophysis. So this is the area where you have to look for the iliac apophysis area, right? So this is the area. So you see that there is a calcification or formation of the iliac apophysis where they grade into grade 1, 3, 4. So from here, if the bone is completely formed till 4th stage, then the skeleton has been matured. So that is called the research sign. Okay, that is called the research sign. So this is mainly about your scoliosis. So you have to remember the two important braces they will ask you as an image based question. One is the Boston brace, the second one is your Milwaukee brace, right? Then what is this? As we have mentioned that the prolapsed intervertebral disc. So they will ask you, as we all know, that there is an L5S1 disc bulge in the MRI, right? Now, which nerve will get compressed? Is it L5 or S1? Which nerve gets compressed? Answer? So you have seen the latest MRI. So L5S1 disc bulge, you have answered it right. But when there is a disc bulge of L5 and S1, which nerve gets compressed? Is it the L5 nerve or the S1 nerve? Yes, very good. This is the S1 nerve which gets compressed. S1 is the nerve which gets compressed. So for understanding this, you have to understand a little small concept which is present. So let us assume that this is your L4 vertebra. So this is your L4 vertebra. So name L4 is written here. And this is your L5 vertebra. This is your S1 vertebra. So L4, L5 and S1 as the names have already been written. Now L4 nerve is traversing like this, right? So this L4 nerve is coming from the L4 and this is the foramen. This is the foramen and it is leaving. So this is called as an exiting nerve. Traversing is now this L5 and S1. These two has to cross this disc and then go to their foramens. So whichever is following to the next foramen, this is called the traversing nerve root. Whichever is exiting at that foramen is called the exiting nerve root. So this is the disc. So this is the L4 and L5 disc. This is the L5 and S1 disc. Right? So if you see, there is a disc bulge here. So usually what we see is the central disc bulges. So in case of central disc bulge, so just imagine now there is a disc bulge here. Now which nerve is getting affected? Is this the L5 nerve root or S1 nerve root? The S1 nerve root, because this is the nerve root which is crossing the L5 S1 and it has goes to the next foramen, right? So that is why this is called as the traversing nerve root. So this nerve root is affected whenever it is a central disc prolapse. But if you see, if the disc is prolapsing at the foramen level, then it will be L5 which is affected, right? So that is why you have to read the question carefully. If it is a central disc prolapse, if nothing is mentioned, take this as central disc prolapse. If they mention specifically as peripheral disc prolapse, or if they tell that there is a foraminal stenosis, then be careful that this is the L5 nerve root in case of your L5 and S1 disc. Okay, if it is a peripheral, all the foraminal stenosis, then it is L5. It is a normal disc prolapse, nothing is mentioned, then assume it as central disc prolapse and you have to answer it as the S1. Clear everyone? Just type an S if it is clear. So this is a test which is called as straight leg raising test. So the surgeon or the doctor with the knee extension is raising the leg straight. So what will this cause? This will cause the stretching of the nerve on the posterior aspect. So especially this is your sciatic nerve, right? Stretching of the sciatic nerve, and this is one of the examples. So again, before that, let me tell you that SLRT is of two types. One is active SLRT, the second one is your passive SLRT. Active SLRT is done by the patient to assess the hip fracture. So if the patient is able to do active, that means he is able to lift his own limb. That is, you can rule out hip fractures. But in case of passive SLRT, it is for your PIVD or lumbar canal stenosis, where you put a pressure on the sciatic nerve, and then whenever there is a wincing of pain in less than 60 degrees. So if the limb is less than 60 degrees and the patient is wincing this pain, this could be a probable of PIVD or lumbar canal stenosis. Right? So less than 60 degrees. If it is more than 60 degrees is wincing with pain, then you have to again examine you have to look for other options. But if it is less than 60 degrees of limb elevation and now patient is wincing with pain, then it is an indication that patient might have a PIVD or a lumbar canal stenosis, or there is some irritation of the sciatic nerve. Right? That is about this. Somehow I am still not convinced with this uphill and downhill. I think I have told it in a reverse way. Uphill we just flex and we go, and downhill we extend and come. I think so, right? Sorry. So while moving uphill, we flex and go. And downhill we extend and come. come down, right? So whenever there is flexion, it is pain free, and on extension it is painful. That is what you remember. Okay, sorry, I don't know, my mind is constantly thinking about uphill and downhill only, so just check. But the concept is, on flexion the pain is relieved, on extension it is very, very painful. Okay, just check if I am right or wrong. Okay, now answer this question, true about given angles. The Bowler's angle is usually 20 to 60 degrees and further increases in calcaneal fractures. Angle of Gissane is usually 95 to 105, further decreases. Q angle increases in patella subluxation. Ligamentum patellae, patellate length is more than 1.2 in patella alta, or Kite's angle is used for club foot. So what are these options here? So are they correct? Are they wrong? What do you think? What do you think about the various angles given here? So do you think A is right or wrong? It is usually 20 to 60 only. But what happens here is, it does not further increase. Yeah, it is correct only, no? 90 to 105. So now there are certain angles which you have to remember in case of your ortho, right? So let me tell you a few angles. So first one is your carrying angle. Where do you see this carrying angle? It is seen in the arm with the forearm. The angle made by arm with forearm, 11 degrees in males, 14 degrees in females, and if it increases or decreases, these are valgus and varus. So whenever usually it is valgus, and if it decreases it is varus, increases it is valgus. So that is carrying angle. Next it is, yes, Yashasvi, you're right. Next it is neck shaft angle. Neck shaft angle is again an angle between neck and shaft. Again you will decide whether it is somewhere it is 125 to 135 degrees, and again coxa varus and coxa valga. Increase is valgus, decrease is varus, right? And then we have what is called as alpha and beta angles. Where is this alpha and beta angles seen? This alpha and beta angles are seen in ultrasound for diagnosing of DDH. What is normal? Normal is alpha more than 60 degrees, beta is less than 55 degrees. Anything abnormal is DDH, right? And then we have your Kite's angle. So what is Kite's angle? Kite's angle is nothing but with talus and calcaneum. The angle between talus and calcaneum, it is somewhere obtuse angle, but it becomes 0 in case of your CTEV, right? Parallelism, which is seen in case of your CTEV, right? And then we have your Bowlers and your Gissanes. So Bowlers and the Gissane, right? So Bowlers and Gissane, what is this? This is seen in case of calcaneum, and this is your Bowlers angle, and this is your Gissane angle. Always remember that is Gissane is gains, increases in calcaneum fractures, and Bowlers low, so it decreases in calcaneum fracture. So these are mainly used to assess the joint reduction in case of your Bowlers and calcaneums. And how do you remember Bowlers? So always there is a point on posterior aspect. If you see a line is drawn, that is Bowlers. Okay, if there is no line drawn on the posterior aspect towards the calcaneum, it is only here, then this is Gissane. That is it. Remember that much, it is N. So if you see there are two lines like this, that is Gissane. If something is back, that is Bowlers. B for back, B for low, Bowlers. So that is Bowlers. And now this is actually the Kite's angle. So there is some angle made between talus and the calcaneum, but in case of CTEV this becomes 0, and this is called as the parallelism in case of CTEV. So that is about your Kite's angle, right? And then we have Q angle, which is called as a quadriceps angle. It is between the quadriceps and the ligamentum patellae. So the patella, there is one line, and the quadriceps, there is one line. This is called the Q angle, and it will talk about your patellar alignment or patellar disruption, right? Called Q angle, patellar alignment. And one more thing is your insalsalvati index for the alta bhaja. So what is the, if patella is normally positioned at this level, if it is high, this is called alta. If it is below, it is called bhaja. So remember, A for A, B for B. Above is alta, below is bhaja. That is how you remember. Proper alta is above, bhaja is below. And for this, we have an index which is called as patellar index or insalsalvati index, where you take this as A, this as B, and this is B by A. That is length of the ligamentum patellae by patellar height. So length of the ligamentum patellae by patellar height. Understood? Patellar height. So this is the insalsalvati ratio, and usually it should be 1 if it is more. If it is more, it is patella alta. If it is less, it is patella bhaja. Understood? So now Kite's angle is for clubfoot, which is very right. Ligamentum patellae by patellar length or patellar height is the same, which is more, it is patella alta. That is also right. Q angle increases in patellar subluxation, very, very right. Bowler's angle is usually 20 to 60 degrees, correct, but it further decreases in calcanea fractures, and this further increases in calcanea. Only A and B are wrong here. Okay, the answer was true about angles, except A and B, all are correct. So the answer is D. So except A and B, all others are right. Clear? Any confusion in the angles? So these are again the various angles which you have to remember. The carrying angle, the neck shaft angle, alpha and beta angles, the Kite's angle, Blowler's, and you have the Bowman's angle, which is used in the supracondylar humerus fractures. It is the elbow angle. That is humerus and the capitulum. It is between humerocapitular angle. Humerocapitular angle. That is the Bowman's angle. Right? So these are the various angles which you come across in the ortho. Next, a 18-year-old patient presented with a history of lower back ache and early morning stiffness. So as soon as you see this important word, that is early morning stiffness, it is related to 18-year-old male. This is something related to inflammation. So once it is inflammation, you have to again think about some inflammatory condition, right? And he's also having bilateral heel pain. So this is again a clue for enthesis. What is enthesis? Enthesis is an area where the ligament or tendon is attached to the bone. The tendons are usually attached, right? So these areas where these ligaments and tendons are attached, there is a calcification or there is some inflammation occurring at that particular area. So this is all related to the inflammation. So this is not a mechanical pain. This is not a disc prolapse. This is not a tuberculosis spine, because this is infection. We are dealing with inflammation here. So this is litis. That is ankylosing spondylitis. Itis is inflammation of the spine. And this inflammation result in fusion, which is called as ankylosis, right? So that is ankylosing spondylitis, which is A, is usually seen in young males of age about 20 to 30 years, and then with morning stiffness, and they are associated with HLA B27, and they also have this extra articular manifestations such as pleurisy, that is inflammation of the pleura, and then they have this uveitis, right, and some pulmonary complication, and they also present with carditis, that is involvement of your heart and your eye, your lung, right? And these are all the extra articular manifestation. And enthesis we have already discussed. And then they all present with the fusion of the spine, so flexion is reduced. How do you know that this is reduced? So you have a test which is called as the Stauber's test, where you examine the flexion of the spine. So forward bending is called the Stauber's test, right? Similarly, one more forward bending which we have, what is that? It is an Adams forward bending test, right? So this forward bending of Adams is usually seen in case of your scoliosis, to decide whether this is a pathological scoliosis or a functional scoliosis, right? So this is the things about your ankylosing spondylitis, and mainly the radiological features. So first thing what you have to remember is that is involvement of sacroiliac joint. It is the sacroiliitis which is very, very, very important to diagnose this condition. Then what you have, there is complete loss of your lordosis. The complete loss of the lordosis, the spine becomes straightened. So involvement of the vertebrae, and then you have a condition called as the dagger sign, where you see there is a calcification of your longitudinal ligament, right? This is posterior longitudinal ligament, which is calcified and representing as a dagger. This is a dagger, which is a small knife like thing, right? And then we have fusion of all this spine, which is called syndesmophytes. Syndesmophytes, and this fusion of the spine appear as the bamboo spine. Very, very important IBQ. So they may put up this bamboo spine or dagger sign, or simply, uh, uh, squaring of the vertebrae, called as the squaring of vertebrae. That means the vertebrae, usually it is like this. So vertebrae is something like, okay, and now what happens is it is completely straightened like this. So squaring of the vertebrae is usually seen, and then you have your dagger sign, sacroiliac joint involvement, and then bamboo spine. Yeah, anterior uveitis, very good. So this is all about your ankylosing spondylitis, right? And what is this? Two important tests again for your sacroiliac joint. One is your Gesslin's test, and the second one is your pump handles test. What is Gesslin's test? You see there is a flexion of this hip, and there is extension of the opposite hip. So this causes pressure on the sacroiliac joint. That's called Genslin's test. And pump handle test is the opposite shoulder. You take this a knee and you try to touch the opposite shoulder. Like this is called the pump handle test. Again, they put pressure on your sacroiliac joint, right? So that is about your ankylosing spondylitis. This is again a very important question. This was asked again in the NEET exam. Whenever a patient presents to you with the high stepping gait, which nerve is damaged? They have put up the X-ray like this last year, last year I think. They have put up the X-ray like this, and they've asked if there is a fracture to this particular area and what is the gait which you expect in this patient. So whenever there is a damage to the CP and the common peroneal nerve, there is a loss to the dorsiflexors of the tibia or the leg, and they result in what is called as the foot drop, right? There will be a foot drop. And whenever there is a foot drop, there is a loss of dorsiflexion, and hence the patient will move with what is called as a high stepping gait. So this is called a high stepping gait. Very, very important. So this area, the neck of the fibula, is where the peroneal nerve turns around. So common peroneal nerve takes a turn around the neck, and whenever there is a fracture in this neck, there is a damage, probable damage to the common peroneal nerve, which will result in what is called as the foot drop. This results in high stepping gait, right? This is very important again. That following a car accident, a patient has come with an intertrochanteric femoral fracture and was treated with this implant. So what is an implant? So implant is one which is put inside the bone, right? And the instrument is one which aids in this implantation, right? Helps in implanting or implant fixation. Instrument is never left inside the body, mind you. Implant is left inside the body, but instrument is never left inside the body, right? So always remember that this hip fractures, this hip fractures, especially the femoral neck fractures, are of two types: IC fracture, IT fracture, right? So this IC fracture is treated by hemiarthroplasty. This IT fracture is treated by proximal femoral nailing, right? Hemiarthroplasty and proximal femoral nailing, both are two different things. You have to always remember the IC fracture, there is an complication of of femoral head, right? So whenever there is a non-union case of femoral head, you again treat it with the hemiarthroplasty. But IT fracture you treat with PFN. Now what is this? What is this implant? Is it a dynamic hip screw? Is it Austen-Wood processes, or it is a femoral nail, or it is a Herbert screw? Okay, yeah, Nischay. That is what I'm trying to explain. No, this one only. Yeah, this is now that you're right. This is a dynamic hip screw. Now I'll tell you carefully. Listen. So now this is yeah. This was asked in INSET only. That was I was trying to explain you. So neck of the femur fracture. Neck of femur fracture. There are two types of neck of femur fracture. So one is called the intracapsular fracture. One is called the intertrochanteric fracture. So one is called the intracapsular. The second one is called the intertrochanteric. Now let me tell you, if this is your neck and this is your femur. So now this is your head. This is your GT. This is your LT. Right? And now this is called the neck of the femur fracture. This is NOF and this is an IC. And now this is called the IT fracture. The pink one is the IT fracture. The red one is the IC fracture. So first you have to identify whether the question was asked for IC or IT. If it is an IT fracture, just mark the answer as nailing. Proximal femoral nailing or dynamic hip screw. So these two can be options. So usually they will ask nailing, that is proximal femoral nail. If it is an IT fracture, if it is an IT fracture. If it is an IC fracture, this particular area, IC fracture, sorry, with red, with this particular area. So here again, it depends upon the age of the patient. Mind you, it depends upon the age of the patient. On the IT fracture, irrespective of the age, it is your nailing only. Here in IC fracture, what happens is you have to look whether the patient is less than 60 years or more than 60 years. And if the patient is having any problem with the acetabulum also, is the patient active patient? That means some patients who are very, very active, the treatment again differs for them. And if IC fracture is seen in less than 40 years or this, you go for CC screws. CC screws are cannulated cancellous screws. Understood? Straight away, if there is less than 40, cannulated cancellous screws in the inverted triangle fashion. So this is the answer for this. Right? This we are done. So IT fracture we are sorted. It is PFN or DHS sorted. IC fracture, if it is less than 40 years, CC screws sorted. Now we are confused only between less than 60, more than 60. If there is any acetabulum pathology, and they will mention whether it is an active patient or a bedridden patient and all. Here you have to choose between two important options. One is hemiarthroplasty and the second one is THR, that is total hip replacement. Okay, total hip replacement is a very lengthy procedure. For that, the patient has to be very, very active. So right away, if they tell there is a IC fracture and the patient is very, very active, more than 60 years, then you go for THR. Right? Now, if they tell the patient is less than 60 years, right, no problem with the acetabulum, okay, then you go for hemiarthroplasty. So please remember, hemiarthroplasty is a surgery. This is an hemiarthroplasty. So here hemi means only half, that is half replacement. So this half replacement is by your femoral head, right? So if the patient is less than 60 years and sometimes the acetabulum is normal, And if you don't want any complications, like sometimes bedridden, even though acetabulum is problem, bedridden patients, which they want, normal surgeries, they go for your hemiarthroplasty. This is your total hip replacement, THR. THR is you're replacing the acetabulum also. Total is total hip joint, that is acetabulum and the femoral head is replaced. This is done for age more than 65 years where acetabulum is also damaged. And even if they're more than 65 years and they're a very active personality, highly demanding, then directly you can go for THR, right? If the patient is bedridden, not so, active, even if it is more than 75 also, you go for hemiarthroplasty. Hope I made it little clear for you. If you have any confusion, let me know quickly. Okay. Thank you so much. I am glad that you understood it well. Okay, now this is it. Just be conscious about you reading. So IT fracture, no doubts. IC fracture less than 40, no doubts. Only if it is an IC fracture, if the patient is having certain, buzzwords, like if she's very active, and the patient is more than 65 years, also she's very active. That means she's a highly demanding patient. So for this above 65 years, if you do only hemiarthroplasty, they again come for THR. So that is the age where usually arthritis set in. So we treat directly for arthritis also. So that is THR. That's it. Now what is this? So now we have understood that this is the DHS implant. So dynamic hip screw. So there is a screw in the head and there is a plate. So this is a dynamic hip screw treatment for IT fracture. And then this is PFN. This is proximal femoral nail. This is proximal femoral nail. So there are two screws. Sometimes there will be only one screw also. Don't worry. This is called nail with the screw in the head is always treatment for your neck fractures. So you see a nail or a plate and a screw into the head. It is treatment for your IT fracture, right? So that is how you remember DHS, PFN. And then what is this? This is an intramedullary interlocking nail. So there is no head here. Head screw is not there. Only screws are there in the bone. Here if you see, the screws are there into the head, right? So this is a screw in the head, screw in the head. So these are treatment for your IT, intertrochanter. And if there are no screws in the head, only screws through the nails, then this is called as intramedullary. So because the nail is inside the medulla, interlocking. So you're locking the nail at this particular sites. So intramedullary, interlocking. There are two types. One is femoral nails. Then second one is tibial nails. These are the implants which you have to identify, right? Age more than 65 years, normal acetabulum, hemiarthroplasty also. Yeah, now if the age is more than 65, now you have to consider whether the patient is an active individual or a bedridden individual. If she is more than 65, an active individual, even though the acetabulum looking normal, but some arthritis will set in because that is the age, above 60, 65 is the age where arthritis set in. So you should always be careful. If the patient is an active individual, you can directly go for THR. But if the patient is not so active and if she doesn't want to go undergo a total hip replacement surgery, then she can go for hemiarthroplasty also. Fine. This is again a tailor-made decision for the patient, individual patients. Is that clear, Yashasvi? If acetabulum is completely normal, hemiarthroplasty, no doubt, right? Is that clear? Yashasvi, I'm waiting for your reply. Is that okay? Should I go ahead? Okay, thank you. Okay, now again important question. A patient was brought to the hospital with complaints of pain around the left hip joint following a road traffic accident. On examination, you see this particular important words. So there is an flexion, there is an adduction, and there is an internal rotation, and there is a shortening. Okay. So what is the most likely diagnosis? Very, very easy question. Very, very important question. So the answer here, you all know, that is posterior hip dislocation. It's a very important topic. So this is again exam based question. So whenever you see a posterior hip dislocation, this is called the attitude of the limb. So the attitude of the limb is flexion, adduction, and internal rotation with shortening. So this is then X-ray. So this is the posterior hip dislocation. So how did I tell it as posterior hip dislocation? So you have to always check for the lesser trochanter. So if the lesser trochanter is visible, very clearly evident, then the limb is in external rotation. If you see here the external rotation, so here you see that the lesser trochanter is easily visible, but here you can see lesser trochanter. Can you make out lesser trochanter here? No. So that means the limb is in internal rotation. So here you can see there is a flexion, slight amount of adduction. So this movement towards the midline is adduction. This is away from the midline. So this is abduction and flexion. So flexion, abduction, and external rotation is an indication of your anterior dislocation, where you see that the flexion, adduction, and internal rotation is indication of your posterior dislocation. And then what is this? This is a central dislocation where you see there is a fracture of the acetabulum. Fracture of the acetabulum. So whenever you see this, there is a fracture of the acetabulum and the head is protruding inside to the pelvis. This is an example of your central dislocation. Oh, very, very rare. It is an indication of a very grievous injury, very violent injury. This fracture, you have to do a complete thorough examination of the pelvis and the acetabulum, because it is a very violent injury and it is always associated with other system injuries, right? So here we are very interested in the father, especially the attitude, right? So what is the vessel which is getting damaged? Most common, okay, in posterior dislocation it is the most nerve, and in anterior dislocation it is the most common, the vessel injury. So here the injury is the femoral vessels, femoral artery, and here the important thing is your sciatic. The most common nerve damage expected in case of your posterior hip dislocation is the sciatic nerve, and here it is the femoral, right? That is about your posterior hip dislocation. And a young man presented to the OPD with the pain and swelling over the right knee following a traumatic injury. And aspiration, he revealed hemarthrosis, injury to which of the following structure would not have led to this presentation. That means they are asking you which of the following are the extra-articular and which of the following are the intra-articular. So not hemarthrosis. So they cannot lead to hemarthrosis. So lateral meniscus, it is inside. Cruciate is inside, only the collateral is outside. So this is the MCL which might not have led to this presentation. So answer is here D. So little about the meniscus. So here this is the tibial tuberosity, and this is your ACL, and this is your PCL. Now if you see, this is your medial meniscus and this is your lateral meniscus. So lateral meniscus is always equal like this. Medial meniscus, anteriorly it is narrow, posteriorly it is wider. This is the basic difference. Anatomy also they will ask. And mind you, the medial meniscus is always related to the medial collateral ligament. So there is a binding of meniscus plus collateral, right? Hence, this is less mobile because of its attachment to the medial collateral ligament. Whenever something is less mobile, it cannot escape the injury. Hence, it is more prone to tears, more prone to tears or more prone to injury. So medial meniscus is one which is more prone to injury compared to the lateral meniscus. And in case of ACL and PCL, ACL is more prone to injury than PCL, right? Now, whenever there are tears, this was also asked in the exam, very, very important. So what do you do with the tears? So meniscus tears, do you remove the meniscus? Do you repair the meniscus? So what do? You remove it or repair it whenever you find a tear. So that to understand what you do to remove or repair, you have to understand the anatomy, that is the blood supply of the meniscus. So now this meniscus I have bought and put it outside like this. So this is the outer aspect. This is the inner aspect. So if you see, the blood supply is from outer to inner. So the outer, it is divided into 3 zones. It is called the red zone. The inner, no blood supply, it is called the white zone. In between, it is a junction, red-white zone. Hope you are following it. Not too confusing or not beyond your scope. Yes. So if you're understanding it, then I will complete it now. So as you understood that there are 3 zones in the meniscus, the red zone, the white zone, and in between is the red-white zone. Now, which tears will you repair? If the tear is in red zone, you repair because there is a blood supply and it will heal, right? And if the tear, if the tear is in white zone, if the tear is in white zone, you will remove it, right? And white, it is up to the surgeon's ability, whether he can repair or he can remove, depending upon the surgeon's ability. So that is how you treat the meniscal tear. So this repair is called the meniscal repair. Arthroscopically we'll do. So we will put the arthroscopes and we will do the meniscal repair. And this is called meniscectomy, that is removing of the meniscus. So this is called the meniscectomy, removing of the meniscus. If it is in the white zone, because there is no blood supply, there is no, so you have to remove this meniscus. If it is in the red zone, you will try to repair with the sutures, and these are specially made sutures which you can put through arthroscope. So this is called arthroscopically repaired meniscus. So meniscal repair is done. So that is it. And what do you do for ACL? Do you repair it or reconstruct it? So ACL, we don't repair it. We will remove the ACL and we will reconstruct it with other tendons. So there are donor tendons like the semitendinous and the gracilis tendon are taken out from the body and they are prepared into the ACL. And this ACL is called arthroscopic ACL reconstruction. This is called arthroscopic ACL reconstruction. That is arthroscopical meniscal repair. This is arthroscopic meniscectomy. So whenever there is a problem in the knee joint, sports injury is now everything through the scope. There is no open cases through the scope. That is called as arthroscope, right? And now how do you test or know that there is an ACL tear or there is a meniscal tear or there is a PCL tear? So there are various clinical tests which are there to understand. So the anterior drawer test is for your ACL. The posterior drawer test similarly is for PCL. The Latchman's test is again for ACL, but this ACL anterior draws should be done at 90 degrees. The Latchman is done at 15 degrees. So whenever there is an acute injury, whenever there is a swelling of the knee, you do the test which is called as Latchman's for ACL. And pivot shift test is again for ACL, which is considered to be the most specific test for ACL. And usually it is done under anesthesia, right? And then McMurray's is for the meniscus. Varus stress test, valgus stress test. These two tests is for the collaterals. So varus is for your LCL, varus LCL, valgus MCL. And Apley's grinding test is again for your meniscus. You put the patient in prone positions and you do external rotation and internal rotation where there will be pain for the patient. This is called as Apley's grinding test. And dial test is for the posterolateral complex, PLC. So this complex PCL, popliteus, popliteus tendon, posterior cruciate ligament, and other one more structure. These three together is called the posterior lateral complex. That is the lateral collateral ligament. Sorry, the lateral collateral ligament, the posterior cruciate ligament, and the popliteus. They three together form the posterior lateral complex, where this can be diagnosed with the help of your dial test. So now this is the, what is this? Knee inflection and now forward protrusion. This is called as anterior drawers test. Similarly, if you're pushing the knee backward, this is called as posterior drawers test. You can just observe, you are stabilizing the ankle by sitting on the patient's foot. You stabilize the ankle by sitting on the patient's foot and your forward protrusion of the tibia. If there is no ACL, there will be a forward translation of the tibia. If again similarly you push the tibia back, if there is no PCL, they will easily, the tibia is translating backwards. That is ACL and PCL. Now what is this? This is stress test, valgus stress test and varus test. So varus stress test. So whenever you give a varus, that means what you do, you are putting towards the midline. That means it is stretching on the lateral aspect. So you will test for the lateral collateral ligament. And similarly for the valgus stress. So valgus stress, you are stretching the medial aspect. So you test for the medial collateral ligament. What you see whether the joint is opening or not. If it is opening, then there is a damage to your collateral ligaments. All these structures are diagnosed by your MRI. You have to take the MRI of the knee and you have to look for these structures, the collateral structures, the cruciate ligaments and the meniscus. Fine. Is that clear, everyone? Okay, a 5-year-old child was brought to the pediatrician with complaints of bilateral knee joint pain. His bone mineral density is normal. The X-ray image of the joint is given below. What is the most likely diagnosis? So what they are trying to tell is the bone mineral density is normal, it seems. And this is a child X-ray, right? And now you have to tell me whether this is a scurvy or rickets or metaphyseal dysplasias or a pycnode dysostosis. So here the answer is mainly the physeal damage which is happening to the patient. Physis is damaged here. All the things you can see is the physis. Right? So this is mainly the case of the rickets because you can see there is a damage to the physis. And what is rickets? It is nothing but your defective mineralization. What is defective mineralization? So there is a decrease in calcium, decrease in phosphorus because there is a decrease in vitamin D. Right? So whenever there is a decrease in vitamin D, whenever there is a decrease in the vitamin D, you see that there is a calcium decrease and the phosphorus also decreases. And these two are very, very important in mineralization of the bone. So before that, let us answer that bone is made up of two structures. So one structure is the collagen. The second one is your matrix, that is bone matrix, your calcium hydroxyapatite, that is your minerals. So there is two important things. So whenever there is problem in this collagen formation, this is called as V. Whenever there is problem in minerals, this is called as rickets. Right? So in rickets, what happened is because there is loss of calcium, you see loss of lucencies around. Lucency is in type of cupping, flaying and spraying. So this is cup. So there is a loss of all these structures, right? So you can't see the structures. Why? Because they are not filled with calcium here. So these structures are lost, which is resulting in cupping. Again, fraying is all those, this type of appearance. And splaying is they go beyond the appearance, beyond the structure. So these are the things which we see in case of rickets. But when you see why, because minerals is nothing but your calcium and phosphorus. And because of this bone, there are various other things which you have to remember. There will be delayed closure of the fontanelle, there will be frontal bossing, there will be swelling, rachitocrusory. This all depends upon of the age. that leads to these symptoms. If it is a neonate, the only thing we see is a delayed closure of the fontanelles. If he is about 3 years, you see rhetoric rosary, you see this bowing of the legs, you see the haricon sulcus and all like that, depending upon the age of the patient. When it coming to scurvy, there is a lot of calcium which is present, but the scurvy collagen is absent. Hence, you see a lot of calcification things, so a lot of white things around, like the epiphyseal ring. So ring, you see there is a structure which is white structure which is surrounding this, right? So this is the curvy, and again you see there is calcification, the Pelkan spur, you see subperiosteal hemorrhages, and this is all again the lucency is scorbatic zone, that is where there is an absence of collagen, that is your scorbatic zone. So this is your curvy, where you see that there is a ring epiphysis, so something which is all white, you see all the white. Where you go for rickets, you see everything is lucent here, this is all lucent. Understood? So that is how you have to identify between your rickets and scurvy. Which one is white line of Frankel? Yeah, the dense calcification is the white line of Frankel. Yeah. That is what I'm telling you. No? The calcifications are seen. So white line of Frankel is, there is a lot of calcification which is occurring there, but there is absence of the bone constituent, that is the collagen. Because question, it says pain in knees. So what do you want to tell, Nishchay? Pain in knees? I didn't understand, but in question it says pain in knees. Yeah, the answer here is actually not rickets, it is curvy only. So that is it. Have the rickets, you have to see there is a cupping, spraying and flaying. These are the terminologies, or you have to see a lot of lucency around the knee joint. And rickets is mainly, okay, see, this pain can be because of the subperiosteal hemorrhages also. Usually scurvy is painless only, but sometimes because of the weight bearing, because of the deformities, patient might end up with the pain also. It is not always painless. And whenever they want to answer it as scurvy, they will give you bleeding gums, and they will tell you that there is other problem in the other parts of the body also, because the collagen is there everywhere in the body, right? So they will give you the clue of that. Okay. Now, what is the following test is done to assess? It is a posterior intraosseous nerve or median nerve, ulnar nerve, or the musculocutaneous nerve. What is this test? Very easy. This is a pen test. We already learned. And what is that thing which he's doing? He's doing the thumb, right? So thumb, I told you, what is it related to? Thumb is always related to your median nerve. So the answer here, it is the median nerve, right? We have already dealt. This also we have dealt. A 28-year-old female patient presented with complaints of gradually progressive swelling around his wrist joint for 5 months. Given below is the image of swelling. What is the most likely diagnosis? So we already know that this is the epiphysis which is involved, right? You can see the epiphysis involvement here, and this is lucent. Something which is lucent in the epiphysis region should be a giant cell tumor. So the answer is osteoclastoma. Very good, median nerve. This one, a 28-year-old man presented with backache, morning stiffness, redness. Fine X-ray has been given. This is a direct question. What is the answer? The answer is yes. Again, it is an inflammatory ankylosing spondylitis. The answer is ankylosing spondylitis. Yes. What is this? Answer 24. What could be the diagnosis of a woman with this appearance in the X-ray? Is it a multiple brown tumors, fibrous dysplasia, enchondromas, or multiple exostosis? Yes, very good. So this is multiple enchondromas. Multiple enchondromas. What is the other name of multiple enchondromas? It is called as the Colliers disease. It is called as the Colliers disease, right? So what if multiple brown tumors you see in case of hyperparathyroidism, and fibrous dysplasia, we have already dealt with it. Polyostotic fibrous dysplasia, McCune-Albright syndrome. Multiple enchondromas is Colliers disease. And what is Maffucci syndrome? Maffucci syndrome, multiple enchondromasis with Maffucci's. Multiple exostosis, I have told you, that is diaphyseal achalasia. So osteochondromas, multiple exostosis is your diaphyseal achalasia. Multiple brown tumors is hyperparathyroidism, and this is multiple enchondromatosis. Whenever you see this multiple enchondromatosis, it is called Ollius disease, or whenever you see this with plebolis, this is called as your Marfus's syndrome, right? Yeah, very good. So this is osteochondroma or exostosis diaphyseal achalasia. This is also a type of cartilaginous tumor, right? Enchondroma. Simple enchondroma, only at one level. That is multiple enchondromatosis. That is Ollius disease. What is this? This also we dealt already. The first question, which of the following is true about the type of fixation which is shown in the image? Fracture tibia, Ilizarov, fracture tibia, spanning fixator, fracture femur, spanning fixator, or periarticular fracture of the knee, spanning fixator. Yeah, enchondromatosis, morphosis is enchondromatosis plus hemangiomas plus plebolis is your morphosis syndrome. What is the 25th answer? D, very good. The periarticular fracture spanning external fixator. We have already dealt with it. Very good. Yes. Now, the patient presented with bone fracture following a road traffic accident. So, there is a fracture of the bone following a road traffic accident. 2 days he developed dyspnea, petechiae involving the whole body. There is a fall in oxygen saturation. What is the likely diagnosis? So, whenever they give complication of the fracture, so complication of fracture, that is especially a femur fracture, and that is after 48 hours. Femur fracture after 48 hours, whenever there is a triad of, first is neurological symptoms, then respiratory distress, the final one is petechiae. So all these three, they together form a triad which is called as a fat embolism syndrome. So very careful about the question. So whenever there is a femur fracture, young males usually, and after 48 hours, whenever they present with this triad of neurological symptoms. So what are those neurological symptoms? They present with confusion, right? And now respiratory distress, decrease in oxygen saturations, and they present with petechial rash or conjunctival hemorrhages. Right, so these are the typical triad which you see, and this is an example of your fat embolism syndrome, right? Followed, everyone? So here the answer is fat embolism syndrome, right? So typically it is after 2 days, that is 48 hours. They present with respiratory petechiae involving the whole body and following the fall in the oxygen saturation. That is your fat embolism. So, intrauterine scan has shown 13th week has shown multiple long bone fractures. So, this I think everybody knows it is nothing but osteogenesis imperfecta. This is defect again in collagen. So, this is called A1 and called A2, which is defective, resulting in multiple fractures. The word multiple fractures, but healing is normal. Healing is normal, but multiple fractures. So this is nothing but a typical osteogenesis imperfecta. Again, you have a triad. So one is osteogenesis imperfecta, then dentigenous imperfecta, where the teeth are involved, and the third one is blue sclera. And again, there is a problem in the hearing loss. Right, so blue sclera, hearing loss, dentigenous, that is involvement of teeth. All these two teeth put together, it is called as your osteogenesis imperfecta. You will see this deformities like this because of the loss of collagen. They tend to bend, and if you see, these are multiple fractures. So fracture 1, fracture 2, and then there is a lot of healing. So these are the lines or lot of healing signs you check. And then there are fractures 3 which has been healed already. So this is multiple fractures mainly seen in osteogenesis imperfecta, and this is your blue sclera. So two triads we have learned, one for fat embolism, the second one is for osteogenesis imperfecta. What is this? Most common complication if left untreated. So this is your lateral condyle fracture. So now we are dealing with complications of fracture. So first one we have dealt with your fat embolism syndrome. The second one is called as a non-union. Non-union is there is no union of fracture, especially seen in the lateral condyle fracture of humerus. So whenever there is a no union, you see what is called as growth of the lateral aspect. The medial aspect keeps growing, the lateral aspect will not grow. This will result in cubitus valgus. So whenever there is cubitus valgus, that means completely like this, away from the mid. And here what happens on the medial aspect, there will be stretching of the ulnar nerve, and this will result in what is called as the tardy ulnar nerve palsy. Tardy ulnar nerve. Okay, so that means there is a stretching of the ulnar nerve. Tardy is nothing but a slow ulnar nerve. So this is gunstock deformity. This is usually seen in case of supracondylar humerus, and here the complication is malunion. Right? So example of malunion: supracondylar humerus, distal radius, IT fracture. Right, IT fracture. So these three will result in malunion. That means there will be some union, but the alignment is wrong. So this will result in what is called as varus malunion. And whenever there is non-union, this will result in what is called as varus, that is cubitus. So here the carrying angle takes the role. So carrying angle, if you see, the carrying angle is nothing but a line which is drawn from the arm. The next is forearm. Arm, and then this is, so that is how the carrying angle is. Usually it is valgus, right? So now varus means it has come to neutral and then gone to varus. Valgus is it, right? So that is how you have to treat the patient. And this varus is by a French osteotomy. So you do the osteotomy, that is, you cut your bone. That cutting is done by instrument called as osteotome. So this French osteotomy is done, right? So what are the examples of non-union? One I told you, neck, that is head of the femur or intracapsular fracture. Second one is your scaphoid. Third one is, so because of the blood supply, the scaphoid waist and the talus neck, these all go into non-unions, and because of their anatomical pattern, the supracondylar, the distal radius, IT fractures, they go into your malunion. Here you can add lateral condyle humerus. Right? Done, everybody with me? Okay, two more questions and we'll end. Right? So that is about the that is about the non-union and malunion. And now try to match all these questions. Very, very important. Your test, the empty can test, the belly press test, the external rotation test, the tennis elbow. Okay, half and half. So here again the test, golfer's elbow and the curvines. So this is about the shoulder. So here shoulder we have four important muscles, right? The sit muscle, the subscapularis, the infraspinatus, the teres minor, and the supraspinatus, right? Supraspinatus, as I've told you, help you in abduction. The infraspinatus, the teres minor, will help you in external rotation. The subscapularis will help you in internal rotation. The basic rule for the test. So empty can, abduction. So this is your empty can, right? You have to abduct. So you put the hand like this and then try to abduct. So very easy. Empty can is supraspinatus. So empty can is B. Then belly press. So I've told you subscapularis for internal rotation. So subscapularis is belly press A. And then external rotation. I've told you the teres minor and the infraspinatus are for your external rotation, right? So that is your T. Then tennis elbow is your lateral epicondylitis, and you do a fist and try to extend the wrist, right? So this is nothing but your Cousins test. So medial epicondylitis is Golfer's test, that is reverse Cousins test, and de Quervain's is your Finkelstein's test, that is the de Quervain's for the APL EPB. We have already dealt with it. So BACEDF. I think the answer is B. BACDF. No confusion. Great combinations, right? Next, a child with a history of recurrent respiratory infections presented with complaints of pain around the knee and a high fever. X-ray shows lytic and sclerotic bone. His peripheral blood smear is shown in the image. Aspirate from the joint will most likely show. So here, see, okay, answer this question, I'll tell you. Is it Staphylococcus, Escherichia coli, Salmonella, Streptococcus? So you see there is a recurrent respiratory infections to the patient, right? The respiratory infections, complaints of pain around the knee and a high fever. So some infection is going on. And now there's lytic and sclerotic bone X-ray, and peripheral smear is showing something like this. Now aspirate, I mean, when you send it for culture, which organism will you isolate? Is it the Streptococcus, the Staph, or Salmonella, or Escherichia coli? So this is an example of sickle cell anemia, right? You can see sickling of the red RBCs, right? In sickle cell anemia, usually the Salmonella is the culprit, right? But also if the Staph aureus is given, you have to always Staphylococcus aureus, right? So the most common is still the Staphylococcus aureus, but in case of sickle cell, you can even think of Salmonella, depending upon your options there. Here they have given two, but aspirate from the joint most likely will show Salmonella. We have given the answer, but in the exam, please be sure there will be some other clue which will tell you that it should be Staph or Salmonella, right? Still, if it is most common, put a Staph aureus. But if they're clearly mentioning, you know, sickle cell is there and you know, some evidence of Salmonella, go for Salmonella. Okay, so sickle cell is usually associated with Salmonella. Here, so that's it. That is the end for today's session. Hope we have covered many questions. So we have covered almost everything. Important things I have covered. The one thing maybe I have not touched is the joints, osteoarthritis and rheumatoid arthritis. Hope you are not very no, it is not very confusing for you. Just remember that osteoarthritis, you have to think about the joint space, and osteophytes are the important findings. Especially in the rheumatoid arthritis, what you have to think is it is the inflammatory arthritis, and there is periarticular erosions, which, and rheumatoid arthritis, there are bilateral, right? And osteoarthritis, it is mainly the medial compartment which is involved, and you have to read about the Herberdin's notes and your Boucher's notes in case of your osteoarthritis, right? And gout, I think you're much familiar with gout, and psoriatic arthritis, you remember the Casper's criteria. And psoriasis, it is mainly the distal interphalangeal joint which is involved, right? So this is about the inflammatory conditions, and infections we have covered, tumors we have covered, and then Boston's and Milwaukee brace, I think you can identify, right? Fine, we have covered. Sports medicine we have covered. Trauma we have covered much. Inflammation, that ankylosing spondylitis also we have covered. CTV we have not covered. Okay, let's do CTV. Okay, now which of the proper sequence for the deformity correction in a child with CTE? So CTEV, mainly if you remember, this is CTEV, that is congenital talipes equinovarus. Talipes. Talipes means talipes. This is ankle and foot. And then there is deformity in ankle, that is equino, and foot there is varus. So that is the meaning of CTEV. And now what you have to remember is only one mnemonic you have to remember, that is CAVE, C-A-V-E. So here C is for cavus, A is for adduction, V is for varus, E is for equinus. right? And then cavus is usually seen in the midfoot. What do you mean by cavus? Cavus means it is like arch. Usually we have these arches, right? Now the arch has been exaggerated. It is like the cave form, right? That is cavus. Adduction is seen in the forefoot. Adduction is all the metatarsal to one side is forefoot. That is adduction. Whereas it is seen in hindfoot, which is related to calcaneum, Then equinus, it is seen in ankle, where the patient walks with the help of toes, not with the heel, like this. That like the horse walks, no? That is called as equine. Yes, Yashasvi, I will just inform the technical team to provide you PDF by any other means. PDF of this YouTube and this lecture will be provided at the end. YouTube, I think it has already been there, and this lecture will be provided in the app itself. You can access it later. So let me complete the CTV. So now this is equinus is ankle, that is you're walking with the help of toes. So these are the various deformities which are present in the ankle and the foot you have to remember. And what is the important thing which you have to remember? How do you correct the deformity? So these are all the deformities in midfoot, hindfoot, forefoot and ankle. So this again you correct in this order which was given by Ponseti. The Ponseti is an orthopedic surgeon who has designed this technique. Before it was Kites who given us. Kites is the technique, but this is very wrong technique he has given. He has first corrected adduction, then varus. That is wrong. First you have to always correct cavus, then correct adduction, then correct varus, and finally you will correct the equine. Will you correct immediately? ASAP, as soon as possible, you have to correct. Even if it is day 1 of the birth of the child, also you can correct this deformity. That is the first day. And how do you correct? You will put serial casing. So serial casing in the order of cavus correction, adduction correction, varus correction, equine. Right? So that is how you will do this serial casing. What is teletram, Naveen? Okay, serial casing. And now what if the patient is if now we have put the serial casing, it will take some 5 weeks to 6 weeks to correct. So now you feel that the completely you have corrected. What will you do? You put this in the Dennis Brown splint. You put them in the Dennis Brown splint. So this splint should be worn for 24 hours initially. Later you can shift it to 12 hours, right? Later you can shift that to 12 hours. Then you put them in the TV shoes when they start walking. So here what you give, there is no heel rise. Heel rise should not be given, and the inner border should be straight. Inner border should be straight. So that is how you treat the patient with your CTEV. So heel rise, there is no heel rise, and the inner body should be straight. So first casing as soon as possible, immediately, there is no delay, and then it will take some 6 weeks. Then you put them in Dennis Brown splint, which is like you have these 2 shoes which are connected by the rod. So this is your Dennis Brown splint. And then when they start walking, you give them CTEV shoes. This is for a newborn. But now what happens? So this is the serial casing what I was talking about. So here you correct K, that is C-A-V and E. Then this is the Dennis Brown splint. So these are the small shoes which are covered by the rod. This is putting in the abduction. The foot will put the foot in abduction. Then you give the this. So what you give this, no heel. There is no separate heel like this. And the inner border should be straight like this. And slight outer raise can be given, negligible outer, because again it should not go into adduction, right? So always you try to put the foot in abduction, and varus should should not go into varus. So for that you make this inner border straight, little raise on the outer aspect, and there is no special heel. So this is the treatment. And now what is the various surgeries you have to remember? If the patient is more than 3 years, what you do is you do deformity correction. So there will be always the deformities which will be present. So you do the deformity correction. If it is 4 to 8 years, you can go for something called as wedge tarsectomy or removal of the bone. If it is more than 11 years, you will go for triple arthrodesis. That is fusion of the joint. So there are triple is 3 joints which we fuse. One is talus and calcaneum. The second one is talus and navicular. And third one is calcaneo. So this is how you treat when the patient is more than 11 years. When he is 3 years, you do deformity correction, and before that you have to remember that this correction is by posterior medial soft tissue release. So this deformity on the posterior structures, on the medial structures, all these structures will go into contracture. So these are the posterior and the medial structures. They are going into contracture and putting the foot in. Now what you do, you cut all these structures. So this is called as posterior medial soft tissue release. And next what you do, know that the medial border is becoming shortening and the lateral border is becoming longer. So now what you do the reverse of it. So now you want to put the medial border lengthening and the lateral border you have to shorten. That's it. That's it, right? So medial border lengthening procedure and lateral border shortening procedure. So this is how you treat the CTEV. So understood? Clear? Any doubts in CTEV? I will definitely take all these queries to our department that this PDF have been stuck and you're unable to access these notes and lectures. And what is this Telegram, Naveen? Telegram. So that is about CTV. Any other things? Any other discussions you want? Any other topics to be covered faster? So not only this app, you can contact me freely on the Instagram also. You can mail me also. I will write all the details here. Instagram, so I've already told you that Dr. Alekhya Ortho. And you can mail me at Dr. Alekhya Sandeep at the rate of mail. This is my email. This is my Instagram. Any topics, any doubts, any help, if you need, you can contact me at any. Fine. So let's call off for the day, or till you want any other topics. All the best. Write well, do well, read the question properly. Don't be in the temptation to answer. Eliminate all the options. The right answer. Let us all know about your experiences on the exam. Come back and tell us what questions were asked and how did you feel about the exam. Okay. Thank you so very much. I really felt very happy teaching you all.